again join to see that whether I am able to join it without any hindrance or not. Okay.
Okay.
Let's see. Leave the meeting. Again join to see that whether I am able to join it without any hindrance or not. Okay. Let's see. Leave the meeting. Yes, comfortable now.
So, Dr. Vikas, your problem is resolved now? Okay, we are going live now. So, please, all of you kindly open your cameras as well.
My camera.
Okay, so good afternoon, good evening, everybody, and welcome to the International Practical Pediatric Endocrine course being run under the auspices of Mediclasses, Growth Society, and Regency Center for Diabetes, Endocrinology, and Research. This is our third online version. We have been conducting a number of practical pediatric endocrine course on site, but this is a unique one which we started during COVID 2 years back, and this is our third session. We are really pleased to have over 32 faculty from across the globe who are part of this program. And I would be inviting the various, we'll be starting initially with the inauguration program. And I like to invite Dr. Rashmi Kapoor, who is the Director of Pediatric Services, Child Health at Regency Center for Regency Healthcare. Dr. Rashmi, kindly inaugurate the session and share your views about the program.
So congratulations, Anurag, for this third online, such a huge global initiative for pediatric endocrinology. And you are actually taking pediatric endocrinology to places. We started from Kanpur to India to now you've become a global thing. And your popularity, speaks by the number of registrations throughout the globe that you've got. And all the participants will definitely be really benefited because this is the only pediatric endocrinology course that has been so painstakingly, taken care of and involving all the aspects of pediatric endocrinology. So congratulations once again and all the best to the delegates from all over the world. And I hope you enjoy this fantastic feast in pediatric endocrinology. And I welcome all the faculty from all over India, and I can see Hemang over there. Welcome, Hemang. Seeing you after a long time. And I can see Dr. Marotra over there. And I can see several new names which I am already familiar with. And so without, coming in between the session and the delegates, I welcome you all once again and hope you will have a wonderful time.
Thanks a lot, Dr. Rashmi, for this wonderful introduction. And before we start with the program, we will have a quick input from the various faculty who have joined us from across the globe. I'll start off with Dr. Deepak, who has joined us from Janakpur, Nepal. Dr. Deepak, you are muted.
Am I audible, sir?
Yes, please go ahead. Yeah.
Okay. So I'm Dr. Deepak Kumar Gupta. I'm currently working in Janki Medical College, and I'm associated with Sir and Regency Healthcare for the last 4 years. I'm proudly can say I have learned quite a lot in pediatric endocrinology, and it's my great pleasure to be here. Thank you, sir.
Thank you. We have got Dr. Vikas, who has joined us from Aligarh. Dr. Vikas.
Good evening, Dr. Anurag Vajpayee, sir. And as you are our sir and honorable and respected Dr. Rashmi Didi, it's 2022 and I have been associated with Dr. Vajpayee since last 2012. The first pediatric endocrine course which we had held at Regency in way back in 2012 in Kanpur. And it's a wonderful journey I have seen evolving and metamorphose the hard work of Dr. Vajpayee. It's a vision and the hard work coupled with a great team. And I can assure everyone who has joined or who will be joining later tomorrow that we'll be having a great feast with excellent academic sessions under the guidance of Dr. Vajpayee. And मेरे पास शब्द नहीं है जिस तरह से मैं देखता हूँ उनको हार्ड वर्क करते हुए एंड पैशन अबाउट द पीडियाट्रिक एंडोक्राइन. सबसे अच्छी बात क्या है, 30 सेकंड में और लूंगा कि he is making expert to the grassroots corners of the India. Pediatric endocrine was supposed to be the branch of the big corporate hospital and elite hospitals. Now in every corner, even Dr. Somani from Bhilwara, she is doing a wonderful job. This is just one example. And I hope in next 5 years, we'll be having our satellite clinics throughout the country, and the vision and the mission will be successful. I wish all the success to this course, and in future looking for more and more such course to the grassroots corner of India. Dr. Vajpayee.
Thank you, Dr. Vikas. Dr. Hemang has joined. Dr. Hemang was a pediatric intensive care fellow in our hospital and now is working as an intensivist. Dr. Hemang.
Hello, sir.
Yeah, so
hello, Dr. Hemang.
Your input. Yeah.
Yes, sir. Actually, I have been associated with this pediatric endocrinology courses since last more than 3 years, and years and years we are gathering more and more participants from across the globe, and this seems to be a huge success for this course. I am congratulating Dr. Anurag Vajpayee sir for this success. Thank you, sir.
Thank you, Hemang. We have Dr. Sumana, who is from Kolkata. Dr. Sumana.
Good evening, everyone. It is a wonderful initiative and endeavor by Dr. Anurag Vajpayee sir and his team. And the program is wonderfully organized, and the way things are planned, the way cases are discussed, I think it's a wonderful opportunity for not only the students, but for also the faculties, and it's a learning opportunity for all of us across the globe. And it is just beautiful to see so many participants from all across the globe, and that pediatric endocrinology enthusiasts are increasing day by day. And all credit goes to you, sir, and your team. Thank you very much. Happy to be a part of it.
Thank you, Dr. Sumana. We have Dr. Bifina, who is from Ernakulam. Dr. Bifina, your words, please.
Hello, everyone. Sir, I consider myself lucky in being able to pursue this endocrinology journey with Anurag, sir. And as everyone knows, sir is a wonderful teacher. And sir, thank you for giving me this opportunity as a panelist here.
Thank you, Dr. Bifina. Dr. Jyoti, who is from Nepal. Dr. Jyoti.
Good evening, sir, and good evening, everyone. It's wonderful getting. It's so wonderful getting so wonderful knowledge from Anurag sir. He's such a great mentor and dedicated teacher. I'm very fascinated by his teaching, and thank you, sir, for teaching us so wonderfully and helping us manage our pediatric endocrine cases and giving the best treatment to our pediatric patients. Thank you, sir.
Thank you, Dr. Jyoti. Dr. Anjali. Dr. Anjali is there from Calicut. You are muted, Dr. Anjali.
Hi, sir. I'm Dr. Anjali, Assistant Professor, MMC Calicut. Thank you, sir, being part of this program. Thank you, sir, included me as a faculty for this program, sir.
Thank you, Dr. Anjali. We've got Dr. Seema, who is from Faridkot.
Good evening, sir, and dear faculty members. I'm very excited, thrilled, and short of word being as a part of this wonderful program. I expect this is a wonderful journey for all of us. Thank you, sir, for giving us this wonderful opportunity. Thank you so much.
Thank you, Dr. Seema. Dr. Riddhi, who was our fellow, and she's now practicing in Vadodara as a pediatric endocrinologist. Yes, Riddhi. You are muted. You're muted.
Hello, good evening, everyone, and good evening, Anurag sir. So, in my residentship days, I was doing this endocrinology, basic pediatric endocrinology course. And because of that course only, I was inspired to do pediatric endocrinology training. And I am very much lucky that I was trained under the best in the field, that is Dr. Anurag Bajpai sir. And today I'm sharing the platform with the sir. Thank you, sir, for this great opportunity and for making me faculty for today's program. Thank you, sir.
Thanks, Riddhi. Dr. Pragya is there, who is currently practicing at Bhilwara and Jodhpur. Dr. Pragya.
First of all, thanks a lot, sir, for bringing us to this international platform. It's really a matter of great pleasure to be a part of this. I would call it an endocrine family. It's like really so good. We are feeling so good to be a part of this program, and I'm sure we would learn a lot and take endocrinology to many more enthusiasts during next 2 days. Thank you, sir.
Thank you. Thank you, Dr. Pragya. Now we have got Dr. Mudita, who is there. Dr. Mudita is currently practicing in Kurukshetra. Yeah.
Yes. Good evening, sir. Good evening, everyone. So first of all, I would like to say heartfelt thanks to sir for inviting me here to be a part of this wonderful program. And I'm sure all the students are going to learn a lot of things during these 2 days. And just few words about sir. I would like to just say that Dr. Anurag sir is Robin Sharma of pediatric endocrinology. So he's the ideal mentor from whom we have learned so much. And, he's the best academician, author, and, the online courses which he has created are helping us a lot. Thank you, sir.
Thanks, Dr. Mudita. We have got Dr. Chisholm, who has joined us from Nigeria. Dr. Chisholm has been associated with us for quite a long time. Dr. Chisholm.
Hello, good evening, everyone. I'm very pleased to be here, and I want to thank Dr. Bajpai for this meeting, for the innovation of creating pediatric endocrinology. I joined 2 years ago because in my center we needed a pediatric endocrinologist. So I've been very blessed to be here, having learned a lot of things so far. And I just want to say that it has never been a wasted experience. Thank you, everyone.
Thank you, Dr. Chisholm. We've got Dr. Alka, who is practicing as an endocrinologist at Fortis Hospital, New Delhi. Dr. Alka.
Yeah, hi, good evening, sir. It's a very nice experience to be associated with you, sir. I'm working as a consultant in the Fortis Hospital CDOC. And first of all, sir, I would like to congratulate you for organizing such a huge, conferences and online courses and giving us the opportunity and a platform and making such a difficult subject a very simple. So, and helping us, and we can help our patient also. Thank you, sir.
Thank you, Dr. Alka. We have Dr. Rashmi, who is working as an associate professor at Mysore. Dr. Rashmi.
Yes, good evening, sir. Good evening, dear all. I'm actually very pleased to be a part of this. I thank Anurag sir for this opportunity, sir. And I have been in association with Medi classes since last almost 4 years now. So I have learned a lot and hope to learn more and more. And thank you once again, sir, for giving this opportunity. Thank you.
Thank you, Dr. Ashmi. We've got Dr. Kamlesh, who is working as a faculty at Jaipur, SMS Jaipur. Dr. Kamlesh. I think Dr. Kamlesh is not there at the moment. We've got Dr. Naveen, who was a fellow with us just recently and now is moved to Lucknow. So, Dr. Naveen.
Thank you, sir. It's first time being on the other side of the stage. And it's a great opportunity for everyone to have a feast in pediatric endocrinology for the next 2 days. It's going to be a great thing. And it's a pleasure always being a part of this academic activity. And I actually miss being in residency, though it is just 2 days, but I miss a lot of things.
Okay, thank you, Naveen. Dr. Vidhu is there from Calicut. Dr. Vidhu. Dr. Vijay Jaiswal has also joined us. Dr. Vijay is the head of department of pediatrics at Meerut Medical College. Dr. Vijay.
Good evening, sir, and good evening all participants as well as faculty. This is a closely knit family and it is ever expanding. And I really appreciate Dr. Anurag sir and the whole team, dedicated team, to really make very simple, methodical and scientific learning of endocrinology in different ways at different modes of platform. So I really appreciate your efforts, sir, and we are always working as a team for the welfare of our children who are having endocrine disease. Thank you so much.
Thanks, Dr. Vijay. We've got Dr. Vidhu. Are you there? So we will be starting off with a small introduction, and then we will have a 2-day program which will cover nearly the entirety of pediatric endocrinology. So why do we really need to have a practical pediatric endocrine course? The reason for that is that there has been a lot of lack of awareness about pediatric endocrine disorders. So we started off with workshops and practical courses which were held across the country. Then we realized that it was very difficult to cover large areas because it is so much logistically difficult. So we started off with social media, particularly with YouTube. And then we started our fellowship program. Now we have got, today we have now got around 10th fellow. Dr. Dhwani has joined as well. So we have got now 10th fellow in our system who has joined the CDR program. Then we started off with our online courses and then finally textbooks and mobile applications. So we have tried to take forward in terms of making it easy and easily available and accessible in that regards. We have conducted a number of courses. The first practical pediatric endocrine course actually happened 10 years ago. So since then we have got a lot of physical programs, but we also now have a lot of online programs which are there. So this is the third online program which we are doing because this provides a much wider access across the globe in that regards. We have our YouTube channel, which has got large number of videos which provide information about every aspect of pediatric endocrinology. There's also an online course which covers various aspects using validated tools. And we've got special courses, including the pediatric endocrinology for fellows, for postgraduates, fellowship in pediatric endocrinology, and a number of programs which are available online, which you can access through our website. We also run routine, regular postgraduate lecture series along with grand rounds using specific cases. So all these are concised in around 8 hours. These ones will run a long time and cover the entirety in that perspectives. And we have got publications which you can access and our mobile application, which will also showcase how it helps in terms of making point of care assessment and diagnosis possible. We are in the process of developing and probably will launch soon about our personalized intelligent EMR, which will allow our overall aspect of care using minimal inputs. Patients will get detailed output with regards to the likely diagnosis, likely evaluation and management. This will make connected clinics through using the e-system, making it much easy to whatever has been learned to implement in that regard. So recently, we have got a lot of programs. People have joined the fellowship program and the diploma program as well. So coming specifically on this International Practical Pediatric Endocrine course, we have got this 2-day program. First is dedicated today on office endocrinology. We'll be covering growth, thyroid, puberty, and DSD. And tomorrow we're going to cover the endocrine emergencies, mainly calcium, electrolyte decay, and hypoglycemia. So 8 modules. We have got 32 experts from across the globe, and we'll have our in-house team, Dr. Sayan and Dr. Vibha will be part of this program who will be conducting. And the way it will work is that there will be case scenarios which will be addressed to specific experts and they will answer. I'll request all of you to keep putting questions on the Q&A part of the chat so that we can address them after each module. So all questions will be answered at the end of the module in that perspective. So without wasting any time, we'll start with the first aspect of our session today, which will be focusing on growth disorders. Now, we all know that growth is a very important part of pediatric practice, and growth really represents the way which differentiates a child from an adult. So growth disorders are something which require extensive evaluation. And we will try to develop an approach in which minimal investigations are used to achieve the best possible outcome in that perspective. So for this session, we are joined by Professor Vijay Jaiswal, Dr. Anurag Katiyar, Dr. Bifina and Dr. Riddhi, and Dr. Sayan will help me out, and we'll try to cover the various aspects about growth in the next 1 hour or so in that perspective. So Professor Vijay Jaiswal is the head of department of pediatrics at Meerut Medical College, and he has been extensively working in increasing the awareness about pediatric endocrinology in that area. And he is being the executive member across our Growth Society, ISPE, as well as UPIAP. So we are really pleased to have him as one of our experts for this session. Dr. Anurag Katiyar is from Lucknow. He is a developmental specialist. He'll be joining us soon. Dr. Bifina, as we discussed, is an assistant professor at Ernakulam, and she is in charge of the pediatric endocrinology clinic there and has been conducting programs on pediatric endocrinology. And Dr. Riddhi Patel, who is a pediatric endocrinologist in Vadodara, who has already joined us in that regards. So why is growth important? So we have this 12-year-old girl, height is 132 centimeters, weight is 20 kgs. Now, when we evaluate this child, the key question is 80% will be physiological and approximately 10% will have a pathology. The question is which child is physiological and which is pathological. We do not want unnecessary investigations in this group, while we do not want to miss this. And this is what we're going to talk about over the next 40 minutes or so in that regards. So when we say growth failure, first of all, we need to understand that it is either physiological, which basically means either constitutional delay of puberty and growth or familial, or pathological. Then pathological means a problem which is intrinsic to the growth plate, like small for gestational age, syndromic causes, skeletal dysplasia. And when we talk about secondary, it could be nutritional or endocrine. So these are the basic parameters. So there are 3 questions that a pediatrician has to answer when evaluating a child with short stature. Is it really short stature? Now for that, we obviously will talk about specific cutoffs and criteria. Next question is it physiological and pathological? And for that, we'll talk about 2 specific criteria. So if your height standard deviation score is less than -2, it basically means you are short. That answer is easy. Next question is what is CDGP? So for CDGP, we use a cutoff of height for the bone age. So if the height is less for the bone age, it is not CDGP. If the height is less for the family, it is not familial short stature. So just looking at clinical parameters, you will identify this. We'll go a bit about that. Then pathological cause, is it primary or secondary? Look specifically for syndromic features, look for body proportions, you will get that. Then you have nutritional or endocrine. So we try to look at specific objective evidences to say what will be an appropriate cutoff in that perspective. So what we found that as the height standard deviation score goes down, the chance of pathology increases. So below -2 standard deviation or more than -2, only 2 to 3% will have a pathological cause. -2 to -3, around 40-50% will have, and less than -3, you will have around 80% pathology. So if somebody is less than -2, worry, but less than -3, don't wait, immediate evaluation is required. And this is what we will use in our algorithm. So anybody who is very short, height is below the first percentile or third -3 standard deviation score, short or not growing, height is between first to third centile, or -2 to -3 standard deviation score and a low growth velocity, and somebody who is not growing at all, crossing 2 percentile lines between the age of 2 years and puberty. Now, this is important. Between the age of 2 years and puberty is something you need to evaluate. And we'll talk about how that is relevant from that perspective. So we'll start with the first case. Dr. Sayan, please come up and start the discussion from there. We'll just check if Dr. Anurag is there. So we have Dr. Anurag Katiyar, who has also joined us. So Dr. Sayan, you can start off with the first case.
Thank you, sir. So welcome to all, and we'll start off with the cases regarding growth. And the first case is that of a 12-year-old girl who presented to us with complaints of short stature. She had a height of 132 centimeter, weight of 28 kg. Her father's and mother's height are presented here. So Dr. Vijay, is the child short?
Thank you, Dr. Sayan. So before coming to any diagnosis regarding short stature, we have to first see the various parameters, that what is the height is, what is the weight is, and how the child is doing in terms of mid-parental expectation. So I would like to see the various information, that what are the various parameters, whether she is fulfilling that criteria to have a normal. So so at present you have given me what is the absolute status of the child in terms of height. Next, I would like to see that what are the various parameters in terms of centile. So we have to see on the basis of that at what centile this actually girl is there. If there is any height standard deviation, what are the parental expectations? So unless and until we are not going to take the parental height, and then nothing is there in terms of absolute. So there will be always a target range. So target height range will be there. And we have to see the corrected SDS score, that is height SDS score, and in that particular girl. And whether there is any nutritional effect on the height, or this is endocrinal problem, we have to see. So the most affected parameter, whether the height is or weight is in according to chronological age, and of course height standard deviation score and BMI standard deviation score to be taken in account. So I would like to plot this child on growth chart.
So thank you, sir, for telling us the basics of a growth chart. And sir, as you just asked, I have plotted the child's growth on the growth chart, and this is what we found.
Yes. So by this information at present, what we can infer that this child, this girl is looking on the lower centile, that is just below the third centile. So you can say that this info, we can say that she is a bit short for the population. But whether this is a pathological short stature, we have to take the account of parental height, mid-parental height. So I would like to see that what is the mid-parental
I have plotted the mid-parental height, sir.
Yes, yes.
Yeah, so this is the chart.
So yes, so now we can see that with this individualized chart for the family, you can see that at present the height is in between the mid-parental height expectation. So for me, this is again, we can see here that what are the affected parameters in terms of what is the height is and what is weight is.
So height and weight is around 9 years.
Yes. So if height is as well as weight is both are at the same pace, that there is no wasting. So it means that this is a normal girl child, and I would like to see in further that in the coming 6 months or 1 year, what is the growth velocity of the child. So yes, so this is a case of familial short stature.
Thank you, sir, for this very important point, that even if a child is thought to be of a familial short stature, we need to follow up the same. And sir, on following up this child over the next 6 months, we found that she has grown, and her growth is 3.5 centimeter over the next 6 months.
Yes, so this is a good thing, that 3.5 centimeter in 6 months, and that growth velocity inculcate 7 centimeter per year. And if I'm going to plot this 7 centimeter per year on 12 year, then we can see here that it is about 58 centile. So this girl is growing very well in terms of growth velocity, And now we can label very safely that this is a girl which is familial short stature. So she is growing as familial expectation. So what is the practice point is that we have to be very sure that correct height for parental expectation. Just don't plot on the single basis. So for this case, no workup if height is within target range, as we have seen in this case. Follow-up is really important in mild growth failure. That can be a pathological thing. Yes, so this is the thing that, so growth velocity really crucial, and we have to ideally see for say at least 6 months, and it will be prudent if you are having for 1 year.
So thank you, sir, for taking us through this case. And the most important point which we take off from here is that even if a child is labeled or thought of to be of a familial short stature, she has to be followed up for her growth velocity and then labeled. Thank you, sir, for taking us through this case. And moving forward to the next case, we have this 13-year-old boy, again presenting to us with suspected deficiency in height gain with a height of 135 centimeter, weight doing fine. Again, her father's and mother's height is presented here. So Dr. Bipina, kindly take us through this case. Do you think the child is short?
Thank you, Sayan. Here we can see a 13-year-old boy with height 135 centimeter. Obviously, he's short for his age. And I would like to, as a first step, I would like the parameters plotted on a growth chart.
Yeah,
so
and
to calculate the height age, weightage, and the mid-parental height.
Yes, so the height age and weightage is around 9.5 years, and his mid-parental height also I have plotted here.
Okay, the mid-parental height is 169 centimeter with a range of 161 to 177 centimeter.
Yes.
And the born age falls at 11 years.
Born age is 11 years.
Yes. Yes. And so this boy has a height below the target range, just below the target range. And as we can see, the testicular volume is also shown here. There is 3 ml, which is pre-pubertal. Since puberty and growth are closely associated, we have always to check the pubertal status for all children with growth failure, and also should be a part of routine growth monitoring after the age of 6 years annually. So since the weight is also affected, I would like to do all the screening tests to rule out the nutritional cause and the chronic illness.
Yeah. So on further assessment, we found out that all the screening investigations are normal in this case. And then on further working up, as the book mentions a lot of investigations for children with growth failure, I went ahead for a basal growth hormone and I found it was pretty low. But then without a stimulation, I couldn't label it. And I went ahead with the GH stimulation test and I found out it was suggestive of partial GH growth hormone deficiency. So kindly suggest to me the growth hormone dose that I should give to this child.
So here the basal growth hormone levels are actually unreliable because it has a pulsatile secretion with maximal secretion at night. So it should not be done as a part of screening. And here the growth hormone stimulation test has been done and shows a value of 6.2, which gives us a misdiagnosis actually of partial growth hormone deficiency. Misdiagnosis because it has not been done with a sex steroid priming because this boy is pre-pubertal. And for all boys more than 11 years and girls more than 10 years, sex steroid priming should be done if they are pre-pubertal.
Thank you. I missed this. I didn't do any priming in this child. So when I did priming in this child, it came out to be 15.2.
So now we know that after this sex steroid priming, which can be done with estrogen for both sexes, that is 17-beta estradiol can be given 2 milligram for 2 days. And after that, if we do the growth hormone stimulation test, it gives us the clear diagnosis. Now the growth hormone is normal after stimulation with steroid priming.
So all screening investigations and growth hormone levels are normal in this child. So the next step?
So we need not give the growth hormone.
So we need to follow up this child, as
Yes,
Dr. Vijay just mentioned in the previous case. And on follow-up, we see that the child is doing well. And at 18 years, he reached the height of his parents. So any takeaway points?
So takeaway points are the born age and puberty are crucial for growth monitoring. And for all pre-pubertal children, that is boys above 11 years and girls above 10 years, the sex steroid priming should also be done before coming to a diagnosis of growth hormone deficiency.
I think that's a very, very important point. 99 boys who come to you at this sort of a height, which is just below the growth chart, are usually CDGP. So you don't need to unnecessarily start working up on everybody. Only if you talk about congenital GSD, they will be very, very short. And acquired GSD may be there, but it's not very common. So how do we identify CDGP? What we have done is that we try to differentiate between those who had an endocrine pattern versus a constitutional delay. And what we found, a simple parameter, if you are short for your bone age, you have a pathological cause. If you are not short for the bone age, you are normal. So if we can use a height standard deviation score for bone age, which is more than -2, it is a constitutional delay of puberty and growth. And we will use this in a simplistic algorithm from there. So as Dr. Bipina said, bone age and puberty are crucial. Consider CDGP in this scenario. And you have to really look at the priming, which is often missed in that perspective. Now, Dr. Bipina talked about estrogen priming. What are the other options in this boy?
Testosterone priming can be done.
So we can give both giving estrogen. Yeah, Dr. Bipina. So yeah, your views on that?
So for both sexes, estrogen can be given. For boys, we can even give testosterone. For 5 to 7 days, it can be given before test.
So generally, it might be sometimes difficult to give estrogen to boys. So we generally give testosterone. It becomes more culturally acceptable in that scenario. But yes, because ultimately estrogen triggers the growth hormone secretion, both genders. So it is absolutely valid.
Thank you, sir. And thank you, Dr. Bipina, for taking us through the case. Moving forward to the next case. This is a 15-month-old girl now with a birth weight which was LGA for the child. Birth weight of 4 kilograms, MPH of 150. Now, she was having failure to thrive after birth and was diagnosed as a case of RTA. So, Dr. Anurag, do you think this is a case of RTA?
The growth is not that much affected as one would expect in a case of RTA. And in this baby, as we can see, the birth rate was also on the higher side, more than 97 percentile, and height, as you can see from the growth chart, is also above 97 percentile. And we can see that what is the expected parental height, mid-parental height?
Yes,
so
sir.
The parental height is on the lower side.
Range of 3rd percentile. So we can see that something has been causing the baby to be on the last side at the time of birth, and it is processed. It is attaining the parental expectation by 2 years of age. So this is most probably not the RTA, but maybe some other cause like infant of diabetic mother, because of which it was a large size baby.
So actually, this is a very, very important message which Dr. Anurag gave, was that the size at birth actually is determined mainly via environment, while size at final height is determined mainly via genetics. And the switch between the two happens typically by around 2 years of age. So this child is large. Now, Sam, you have to tell me what was basically the parental expectation.
So was on the lower side, and he's catching up for that only.
So this is the parental expectation on the 3rd centile. So this child was destined to be short, but was born large because the mother had diabetes. So now in this context, Dr. Anurag, do you think that this child required so much evaluation? Dr. Anurag? I think we have lost Dr. Anurag, but so this case clearly.
Can you hear me?
Yeah. Now we can hear you.
Yeah. So during first 2 years, we can expect some crossing of major lines in a child, and that comes up to the parental expectation only. So within first 2 years, we can. Hello.
Yes, sir.
Yeah, carry on. Yes. Yeah. So it is normal for the first 2 years to have a catch up or catch down growth. If it is in accordance to the parental expectation, you don't need to do any further evaluation. And if you see this base axis of -7, this is a very marginal thing. If you've done so many investigations, you will find it to be abnormal. So, Doctor, what are the message, Dr. Anurag, you would like to give?
Yeah, size at the birth is determined by the environment. That is, in the intrauterine environment, the baby was exposed to high sugar levels, so it was large size baby. And the adult height is expected is determined by the genetics. And this switch from occurs by 2 years of age. So crossing of the major lines in first 2 years of life is not to be considered abnormal, and no workup may be needed for this period.
Yeah, thank you, sir, for taking us through this case. This was the point which sir also said when introducing about growth failure. The child not growing at all, only between 2 to 18 years will need to be worked up. And if crossing cell ties between 2 years, but reaching as per the parental height, do not work up at all. Thank you, sir. Moving forward to the next case. This was a 10-year-old girl having short stature, but also underweight. Was diagnosed as a case of growth hormone deficiency and referred to us. So, Dr. Riddhi, kindly take us to this case, having short stature as well as being underweight.
Okay, so sign first, I would like to see the growth chart of this boy.
Yeah, I have plotted the same for you.
Okay, so here we can clearly see that height age is 7 years and weight age is 5 years. So weight age, which is more affected as compared to the height age. So as we have discussed, it can be the nutritional cause of growth failure, and which all other parameters were used to diagnose her as a growth hormone deficiency.
Yeah,
so what all workup was done?
I'll tell you those. The hemoglobin was on the lower side. We did the TTG also, as we were suspecting a nutritional cause, but the TTG was normal. And then we went in for a karyotype, which was also normal. Here, the IGF-1 was low and the basal growth hormone was low. That is why we diagnosed the same as a case of growth hormone deficiency.
Okay, so here all the screening workup, though it is normal, but clinically child looks like nutritional cause of growth failure. So we have to rule out all other possibility of malnutrition or malabsorption first before doing the hormonal workup, because here weight age is more affected as compared to the height age. Sign, do you think here most important investigation is missed?
The most important investigation, which are you speaking about, Dr. Riddhi?
So this is the bone age. So when we are encountering any case of growth failure, the three most important investigation, I would say, one is the detailed clinical examination in history. Second is the detailed interpretation of growth chart. And third is the bone age. So here bone age actually is missed in this case. And we should look at the bone age first before doing
the main problem of bone age is that most people don't know how to do bone ages. So can you give a quick guide, a 2-minute guide about how to assess bone age?
Yes. So actually bone age is routinely prescribed investigation in each and every patients of growth failure, but it is difficult to interpret, especially at the level of pediatrician and general physician. So before doing the bone age, we have to keep in mind some precautions that always talk to radiologist before prescribing the bone age prescription. Please take the full left hand x-ray. So always write the prescription type like x-ray left hand and wrist, including fingers. Don't cut the distal epiphysis or middle epiphysis, because whole hand x-ray is required for the exact calculation of bone age. Secondly, fingers should be spread apart. And third, exposure should be proper. That's so that we can assess the each and every parameters of the morphology of the small bones also. Now there are...
the other thing with these is that which bones to focus on?
So mainly we have to focus on the smaller bones, that is the epiphysis of the fingers and metacarpal bones and radius and ulna. Actually, old textbook and even I was using the method of calculating the number of carpal bones to assess the bone age in my residentship days, but that is the useless method, because there is the variable in appearance of the carpal bones, and that is useful only in first 2 to 3 years of life. After that, that method is not useful. So in first, girls have more advanced bone age as compared to the boys, and that is 2-year advancements because of the effect of estrogen. So in first 2 years, we can see that number of carpal bones can help us for the bone age. After 2 years in toddler, 3 years in boys and 2 years in girls, number of smaller bones, that is the epiphysis in fingers and metacarpals and distal phalanges and middle phalanges, help us to calculate the bone age. And after that, 2 years to till pre-puberty, we have to see the exact morphology of the smaller bones, that is the size of epiphysis, whether one white line is visible, whether two white lines are visible, or whether capping has been started or not. And after the puberty, whether fusion is started or not, that help us to calculate the bone age. Still, this method, that is very, very rough method to calculate the bone age, and that is not helpful for the accurate assessment of the bone age. And there are other methods are also available, like Tanner-Whitehouse 3. There is mobile application available for Tanner-Whitehouse 3. Grulich-Pyle method. Also, Bone Expert is available. But all these methods are very cumbersome except Bone Expert. Bone Expert is easy. That is that gives us the report only in 2 minutes, but that is very costly. That is not feasible at each and every center. And Tanner-Whitehouse 3 is very cumbersome method that is difficult to apply in routine busy pediatric practice. It takes around 10 to 15 minutes in unexperienced head. And Grulich-Pyle method is also not the ideal method to do at the pediatrician level. So we have been trying to develop the easy method for bone age assessment, and we have come up with this mobile application where we have to select morphological feature of only 5 bones, that is the middle and proximal phalangeal epiphysis of middle finger, proximal phalangeal epiphysis of thumb, radius, and ulna. With only these 5 bones, we have been able to calculate as precise and as accurate bone age as Tanner-Whitehouse 3. So this is very good method. It takes around only 2 to 5 minutes, and we have validated this method, and that has been accepted for oral paper presentation at national and international conferences. So
congratulations, Riddhi was part of the team which developed the mobile applications. We'd like to congratulate Riddhi for this. And this is easily available and you can get the bone age done. So bone age, as you Riddhi said, is the most important thing, but unfortunately not done in that perspective. So now we'll go forward on the case. What do you think was wrong in terms of the growth hormone assessment was done, Riddhi, in this case?
Yes, so here in this case, the girl is diagnosed with the growth hormone deficiency on the basis of two parameters. One is the IGF-1. That is the actually screening test for growth hormone deficiency. But as we can say that growth hormone, IGF-1 is group screening parameter for diagnosis growth hormone deficiency, but it has some limitations. It is age dependent parameter. This study has clearly shown that less than 6 years of age, it has no role in diagnosing growth hormone deficiency or screening growth hormone deficiency. Plus it has effect of nutrition also. So those who have malnutrition, in India, malnutrition is the most prevalent cause of growth failure. So here IGF-1 is not the reliable marker to screen for growth hormone deficiency. And second one, growth hormone has pulsatile secretion. Also, it has diurnal variation. So it has to be done growth hormone stimulation test. There is no role of basal growth hormone to diagnose growth hormone therapy. So the two wrong criteria were used to diagnose growth hormone deficiency, and falsely C is labeled as growth hormone deficiency. So can we say that what was further workup done in this case, Sayan?
As you just mentioned, we should always go by the growth chart. And as you clearly mentioned that this was a nutritional pattern, we went ahead with the IgA levels in this child because the TTG was normal. And in this case, we found that the Ig was undetectable. So the next step was a duodenal biopsy and it showed a villus atrophy. So what do you think, Dr. Riddhi? Dr. Riddhi?
So this case clearly, as Dr. Riddhi said, the diagnosis based upon IGF-1 is more unreliable because this is malnourished and it is so that's why we have a falsely low IGF-1. So here IgA should have been done ideally before we had done the evaluation. So IgA was undetectable and therefore there was an improvement in growth. So the key messages here are that if your weight is less, so the most important thing to look at in a short child is actually the weight and not the height. If the weight is less, this indicates a nutritional pattern. If the height is more affected, it is just an endocrine pattern. And if you're suspecting celiac disease, maybe first go with TTG. But if TTG is negative and you have a high pretest probability, get IgA level done. That is very important. And IGF-1, of course, is not, we are not big fans of IGF-1. It's not good in malnutrition, definitely, in that scenario. And if you want to waste money, you can burn it, but don't do a basal growth hormone. The only role of basal growth hormone, Cyan, is GH insensitivity. So if you are strongly suspecting growth hormone insensitivity, height standard deviation -5, triangular facies, they have got frontal bossing, sparse hair, then you can do a basal growth hormone. And if it's more than 5, you may think that this could be a insensitivity in that scenario. So we'll move forward to the next case. And
moving forward to the next case, this is an 8-year-old boy. Again, short, again, weight is not that low, diagnosed as a case of celiac disease. So Dr. Vijay, do you agree with this diagnosis just by the clinical parameters that as Dr. Riddhi just mentioned?
No, definitely not, Dr. Shayan. I have to see again, we have to plot on the growth chart, and again, we have to interpret in, yes. So by this parameter, what I can see here, that what is the most affected parameter, and the most affected parameter is height age. That is, height is the most affected parameter, and then weight age to chronological age. So
yes,
here,
so height age is 3.8 in this case.
Okay, so height is, and what about this weight age?
Weight age is around 5.9 years.
Yes, very right. So go ahead, please. So we have to see the cause, that here the most affected parameter is height age. So
yes.
I would like to see the bone age as well as these interpretation, that what is the bone age in this child. And then we have to see that whether the weight age is preserved mostly. So if
it was significantly delayed, Dr. Vijay,
yes,
and the diagnosis of celiac was based only on TTG levels rather than on actually a biopsy.
No, definitely. So here I want to add that please don't be misguided. So there is clear-cut SPGN guidelines that how to go about these things. So we have to really weigh upon whether what is the cause, whether the nutritional versus endocrine. So if the most affected parameter is weight age, then of course it is nutritional. If the most affected parameter is the height and the weight age is relatively preserved, it means that we are going to deal a cause for mostly endocrinal. So this is really important, that a plumpy child, plumpy short child is, we are dealing with the endocrinal issue. Contrary to that, thin child, that is malnourished child with stunting, probably we are going to deal with nutritional, either less nutrition or malabsorption. So we have to really weigh upon these things.
So Dr. Vijay, there is a big confusion about celiac disease. When I had come, nobody used to believe that celiac disease is common in this part of the world. And now everybody thinks everybody is celiac disease. So
Yes.
what are the specific guidelines you like to follow? So this case, clearly, as you discussed, we did a biopsy and which was normal. Growth hormone stimulation showed a growth hormone deficiency, which is quite expected because
Yes.
this looked like an endocrine pattern. And MRI showed a hypoplastic pituitary. So this was a classical case. But I think what we want you is to focus on what will be your guidelines as far as the SPGN and other suggestions with regards to how do we evaluate a child with suspected celiac.
Yes. So if I'm going to see this SPGN guideline, so it is clearly shown that mere positivity on this basis, you can't label as a celiac. So if TTG IgA based is negative, and we have to take the account of IgA. If IgA is normal, so then you can safely rule out that there is no celiac disease. But if there is IgA deficiency and your test is dependent on that, so there can be false negative celiac can be there, and it is always better to refer these children to the gastroenterologist part. If there is borderline increase, that is, if TTG IgA is increased by 1 to 10 times in range, then before labeling this diagnosis of celiac, it is always mandatory to have biopsy. And even in biopsy, what we are going to see the tissue diagnosis, that what is the label of mass grading, that is blunting of villi and so many things. So if mass grade 0 or 1 is there, we can safely rule out that celiac disease. So there is no need to have gluten-free diet in this. If Mars 2 or Mars 3 grade is there, then probably tissue has been affected and the child is going to have malabsorption. So it is prudent to manage as a case of celiac disease. And if TTG IgA is beyond 10 times, then we have to see the EMA antibodies. If it is negative, biopsy, and if it is positive, there, since it is very high antibody titer, and this EMA is positive, so 2 positive antibodies. So we can avoid in this case a biopsy, and we can manage a whole case like a celiac disorder.
So if we just look at these 2 cases which we discussed, which caused a diagnostic dilemma, the first one was TTG was negative. The child had a high index of suspicion, so IgA should have been done in that scenario. The second sscenario was TTG was 1 to 10 times the upper limit. So here the biopsy should have been done. So both the cases could have been evaluated in that regard.
Yes.
So Dr. Vijay, so now this is a big issue, that whether it is nutritional or endocrine. So what we did in part of our evaluation is whether we can use a specific criteria. So we talked about CDGP. We also looked into nutrition and endocrine. What we found is that if your BMI standard deviation score is below -1.5, it suggests a nutritional pattern. But celiac can happen even if somebody's BMI is not low. So while it is good that we are talking generally that, okay, if you are short and lean, then you think of celiac, but you can sometimes have short and normal weight also who can have celiac. So you need to be aware about that. That's why TTG has to be done in every other case. Another scenario is inflammatory bowel disease. So if you are 10 years and above and short and nutritional pattern, you should do a IBD workup. And which test will you do, Sayan?
It's a fecal calprotectin.
So we can do it fecal calprotectin for that in that perspective. So Dr. Vijay, your practice points from this?
Yeah, definitely. So think endocrinal cause in short and plump. Right? So nutshell, chota or mota bacha, then we have to see for endocrinal problems. Biopsy is mandatory to diagnose celiac. So please don't label celiac disease and don't start diet therapy just on the basis of antibody parameter.
So next case, Sayan?
Moving forward to the next case, this is a 6-year-old boy, now very short and underweight, diagnosed as a case of nutritional rickets. Now you can all see the picture. This is rickets clinically. Now what happened is that even with a label of nutritional rickets, on multiple doses of vitamin D, did not recover. X-ray still suggestive of rickets. Now when you see the blood parameters, the ALP comes out to be normal. Along with that, we have a low potassium. Now, I can't explain these findings. So, Dr. Bipina, can you just explain these findings to me? Rickets not improving on multiple vitamin D courses and having a normal ALP with a low potassium.
Okay, this child has already diagnosed as nutritional rickets, not responding to multiple doses of vitamin D. And we can see that the calcium, phosphorus, alkaline phosphates are all normal with the low potassium. So we have to think of other causes of rickets like renal tubular acidosis, chronic kidney disease and all. And we have to rule out this. So I'll order a blood gas here.
Yeah, so on the blood gas, these are the findings.
Hello.
Okay, we can see that here there is metabolic acidosis and the anion gap.
Urine anion gap was positive. Yeah.
Okay, this is the normal anion gap metabolic acidosis, which suggests renal tubular acidosis. And the urine pH, can I know?
Urine pH was 6.8.
Okay, here the urine pH is more than 5.3. And on the ultrasound, we can see nephrocalcinosis also. So this is a clear-cut case of distal renal tubular acidosis.
Yeah, so this was the diagnosis that we missed. And we labeled the child as nutritional rickets, when actually we had to think of other causes of rickets on having the child on multiple courses of vitamin D, not recovering, and also having a normal ALP. So kindly take us to the practice points here, Dr. Bipina.
We have to think of renal tubular acidosis in all children with rickets and growth failure. And another message is that we also should confirm that the renal function tests are also normal. Yes. Low potassium is an important clue for renal tubular acidosis. And blood gas and urine pH can help us in making the diagnosis.
So, Sayan, what are the causes of rickets and growth failure other than RTA?
So rickets and growth failure will be CKD.
Yeah, and?
So I can remember only RTA and CKD in this.
Celiac disease.
Okay,
celiac. So this is a very more common will be celiac disease actually. So you have to consider all the possibilities there. Carry forward.
Yeah. So summarizing all, just by plotting on the growth chart, we can find out familial short stature. We can definitely diagnose CDGP. And then even if the biochemical tests point to other causes, we can definitely differentiate nutritional and endocrine causes and work up on the basis, just on the basis of a growth chart. So this is the message we are giving, that growth chart, anthropometry is the primary thing that we need to do in all these cases. Moving forward to the next case. This is a 14-year-old girl with a height of 120 centimeter and a weight of 32 kgs. Now, this is the picture of the girl. She had a normal screening parameters, had a normal TTG. So, Dr. Anurag, what do you think is happening with the child? She's very short.
This is a girl who is very short, so we should always keep a possibility of Turner syndrome in all the short girls. And in this case, we can see the clinical pointers towards the Turner, that is the web neck, the widening of nipples, and the brachymetacarpia is also there. So this is definitely a case of Turner syndrome. And yeah.
So we went ahead with the FSH, which was 72.
Yeah. So FSH is higher, so that also points toward the Turner syndrome. But in all these cases, we should always go for the karyotyping. So we have to look for the Y cell line if there is any mosaic pattern.
Yeah, this is the most important thing, and this will also come up during puberty. That why do we need to do a karyotype even if we are confirmed that this is a case of Turner syndrome? So what are the practice points in this case, Dr. Anurag?
If the Y cell line is there, then these will be associated with gonadoblastoma. So we need to do gonadectomy in these cases. So the practice points are consider the Turner syndrome, all the short girls, and karyotype is mandatory even with high FSH. And we should screen for associated defects like cardiac defects or the hearing problems, and growth hormone is needed, therapy is needed in all these girls, and there is no need to go for growth hormone stimulation test before starting the treatment.
So we have talked about three important pathological causes: celiac disease, Turner syndrome, and RTA. Now let's put it, when do we need to evaluate? I would say celiac disease evaluation is required for everybody who has growth failure, because we have even seen if your weight is normal, you may have celiac disease. What about renal tubular acidosis? The general message is that if somebody is less than 3 years, you should definitely do a blood gas. Beyond 3 years, if you have polyuria, if you have rickets, if you have other features, then you assess. Now, karyotype, of course, you should do in all girls, but after you have done all the evaluation. You don't want to do somebody as celiac, you go and then you do a Turner evaluation in that perspective. So if you have checked everything, then think of Turner syndrome. But another message is, often Turner is associated with other causes of growth failure. It could be celiac, it could be hypothyroidism. I have seen patients with hypothyroidism who are actually Turner who are missed out. So always be wary that if your height is disproportionately low, whether Turner is also there. So this is a very important message that Dr. Anurag gave in that regards.
Moving forward to the next case. Now we have a 5-year-old boy with a birth weight of 2.1 kg. His mother complains that he's growing poorly since birth, having normal development, but just look at his height and weight. Even for a 5-year-old, his height is 90 centimeters and has a weight of 10 kg. This is the growth chart that we have plotted. And Dr. Riddhi, kindly tell us, what can we do about this child?
So this is definitely SGA child, because his birth weight was only 2.1 kg, so small for gestational age child, and current age is 5 years. Still the child is growing below the 3rd centile. So this child definitely need growth hormone therapy, because SGA, which is not growing properly even after 4 years of age, need growth hormone for the height increment, for anthropological improvement. So growth in SGA, actually there are two groups of individual. One who bone is low, then their growth remains slow throughout the years of toddler and childhood, and even they remain short during the puberty, but they have chances of early puberty. They have chances of precocious puberty. So they have their final height remains short as compared to the other individual, but they have no metabolic complication. They remain healthy. While in other group of individuals where the birth weight is low, but they show rapid catch up and their growth is rapidly advancing throughout the years of childhood and puberty. And they tend to show the weight gain, even obesity during the pre-pubertal and pubertal years. Their puberty remains at the normal age, but they have unhealthy. They have higher chances of development of metabolic complications like type 2 diabetes, hypertension, and dyslipidemia, non-alcoholic steatohepatitis. So in SGA, we have to carefully follow the growth chart. Okay, so if the child is rapidly growing, we have to we have to counsel them for the metabolic complications, and they can through the metabolic complication, we have to give counsel for the dietary restriction and even physical activity. And those who are not growing properly, they need growth hormone therapy after 4 years of age, even they remain their growth remain below 3rd centile. So in this study, it is clearly shown that percentage of children that remain below 3rd centile, they tend to grow below 3rd centile, that remains static after the 4 year of age. So even at 8 year of age, 10% of children will not grow further and they need growth hormone therapy. So maximum catch-up occurs by 2 to 4 years of age. So practice points in this case are monitor the growth in SGA child. They can have rapid growth or they can have slow growth. Wait for catch-up growth only up to 4 year of age. There are 2 guidelines, but we can maximally wait up to 4 year of age. Even after 4 year of they are not growing, growth hormone therapy is advisable. Assess for the other treatable causes of the growth failure like nutritional causes and celiac disease and other malnutrition. And there is no need for growth hormone stimulation test. You can directly start growth hormone therapy based on the growth chart and the birth weight parameters.
So very important message, 2.5% of all children are SGA. But if you talk about adult tall stature, 20 to 25% are SGA. So if you have a SGA child, he has 10 times the chance of developing short stature as an adult as compared to the other age group. So if you want to prevent adult short stature, SGA is a very important group to identify early and treat also in that regards.
Thank you, sir. Thank you, Dr. Riddhi. Moving forward to the next case. This is the 10-year-old girl, again very short. Weight is 24 kgs. Now, in this case, we have all the normal screening tests. TTG was also found to be normal. And Dr. Vijay, then after all the screening tests, now should we move ahead with the karyotype in this case, as this child is a girl? Dr. Vijay?
Definitely. First, we have to see that in picture, what I can appreciate that this is a 10-year-old girl, and definitely she is having pathological short stature. But there are many more pointers along with this short stature that I would like to see the correct anthropometry in terms of what is the upper and lower segment, what is the ratio of upper to lower segment. Yes, so definitely. Yes. So you can see that upper segment is quite more in comparison to lower segment. For this is what we expect that it is going to be 1:1. And here again, infantile parameters are there, that is upper to lower segments are skewed. So this is probably maybe a case of skeletal dysplasia, and here not karyotype, rather I would like to see the genetic studies for presence of mutation, and that is FGFR and other things.
So the mutation showed FGFR, as you said, sir?
Yes. So whether this is positive for that mutation?
Yes, sir, positive for that mutation. And also thank you, sir, for correcting me again that again, without performing the basics of growth chart and anthropometry, I thought of the investigations first. So again, thank you, sir. Yeah.
So the learning point is that we have to see the body proportion is important. So detailed clinical history as well as detailed examination, we don't forget, we never forget. And so this was a case of hypochondroplasia resembles rickets. So it is really very important to do all the parameters, and no need for extensive testing. Again, we have to look back that at what age the child was having this insult. So probably she was having short stature since beginning or very early in the life. So there are so many things what we have to take, and not only the karyotype, but genetic testing for prenatal diagnosis, because the parents are going to ask, yes, what about next child? So it is really important for that child and for the next progeny.
Thank you, sir. Thank you for your wonderful message. Moving forward to the next case.
So now we've discussed about various cases. Now we'll just try to use those cases as a concept to build up the algorithm for evaluation. So the first question is the child short? We look at height SDS. If height SDS is above -2, follow up. There is no need for urgent evaluation. If the child is short, my next question is the child short for the family? So you use the corrected height standard deviation score. If it is above 1.5, then you don't need to do it. It is familial short stature, follow. Now the child is short for the population, short for the family. The next question is he short for the bone age? Here, if it is above -2 standard deviation, the height standard deviation for bone age, this is CDGP. So these three will actually be 80 to 90% of what the pediatricians will see. You do not need a lot of evaluation there. But if the child belongs to the other things, you do a screening. And this we will include all workup like CBC, ALT, creatinine, TTG becomes important. Thyroid, of course, and blood gas before 3 years of age. Now, if all these are normal, you follow up. Or if your child is very, very short right at the beginning, or they are not growing, so in that scenario, you look at systemic features, you look for syndromic association, upper segment, lower segment, facies. If that is normal, do a IgA, because now you don't want to miss celiac and a karyotype in blood. You are saving a lot of investigation. You are not doing unnecessary investigation at this point of time. And then if it is normal, then go for growth hormone stimulation. So do not rush with growth hormone. It should be a very last. From our study, probably you will need in an endocrine clinic also around only 20% will require a growth hormone stimulation. A pediatrician will be like 5% also. So don't rush with growth hormone. And then you diagnose GSD. We don't believe a lot in IGF-1. Only if you're thinking of insensitivity, IGF-1 will help. And then you can classify from there. So the three key parameters are height standard deviation score, corrected height standard deviation score, and height standard deviation score for bone age. These three will give you a real picture and you will be able to evaluate. Now, how do we use all this algorithm in our busy clinical practice? So what we have done, and this is Riddhi was the primary author in this, that we developed and validated our mobile application growth interpreter, which basically provides, based upon key inputs, you will know what is the most likely diagnosis based upon all the parameters I talked about. You don't need to calculate them, it will give it automatically. And what we found that there was approximately 99% concordance in what the app said and what our actual clinical diagnosis was. So we have developed this tool which you can use easily, which will help you guide in terms of evaluation and management. This will of course not replace clinical judgment, but will help out in managing in that perspective. Now we move towards the other side, Sayan.
So now moving forward from growth to obesity. Obesity is a very common thing that we face, all face in our pediatric practice. Out of the total patients that we have, they come to around 5%. But the most important thing is that the most common cause of obesity for today is physiological. The disorders account for only 2% of the cases, and we'll tell you how to distinguish between physiological and pathological causes of the same. So careful assessment is required, and the physiological obesity you can differentiate based on normal growth, normal development, and normal puberty. These are the three things that you will get in physiological causes. In pathological causes, they will be early onset, will have hyperphagia, and will also have other associations like vision abnormalities and all the likes. And they can also have other associations with other medications causing obesity for the same. In endocrine causes of obesity, you will have a short and plump child, if you remember what Dr. Vijay said.
So most important when you want to evaluate, this is our algorithm for obesity before we go ahead with cases. First, look at the obesity criteria. If the child is not fitting, no worries. If the child is fitting and he is less than 5 years. Now, this is a criteria for genetic obesity. Less than 5 years, very obese. You would need a genetic study. Less than 5 years, less than +3 standard deviation score, or somebody who is above 5 years, look for syndromic features, development, vision, and dysmorphism. Normal growth, normal puberty, normal development, unlikely to be a genetic cause, don't need an evaluation. But if you have syndromic features, you need to do a genetic testing. And this could include evaluation for Prader-Willi syndrome first, because that's a methylation study, and then go forward towards a targeted panel. But this will be less than 1% of all of your children. So less than 1% will have a genetic or a pathological cause. The other thing, you look at height. If your height is compromised, do an endocrine workup, and otherwise, if it's more, you look for a complication screening. Now we'll start with the cases, science.
So moving forward to the cases, this is a 12-year-old boy who presented to us with obesity, had a height of 160 centimeter, had a weight of 70 kilograms. Now had a TSH on workup, it was found. He had a TSH of 7.91. Now was advised thyroxine. The child came to us and wanted to know the dose of thyroxine that we would prescribe him. So Dr. Vipina, what is the dose of thyroxine that we would prescribe in this case?
So this is a 12-year-old boy with the height and weight as shown here. Can I see his growth chart?
Yeah, this is the growth chart.
Okay, so as we can clearly see, this is an obese tall child. So usually hypothyroidism causes an obese short child. So here we should not be thinking of this subclinical hypothyroidism, or FT4 should be normal, and mildly elevated TSH is the effect of obesity and not the cause of obesity, because in obesity the leptin will be increased and this will stimulate the TRH and cause a mild slight increase in TSH also. And this TSH will come down with weight reduction. Treatment is required only if the TSH is more than 10 or between 6 to 10 with features like goiter or anti-TPO antibody positive.
Yeah, thank you for this very important message, because this is a problem that we very commonly find. Obese child having a borderline TSH which is raised and given thyroxine. So the wonderful message that Dr. Vipina gave us, in these cases, we should not start treatment.
So subclinical hypothyroidism is present in around 40% of children who have hypothyroidism. This is from our study which Riddhi had done. And what we found interestingly is that if somebody has subclinical hypothyroidism, they have a higher chance of steatohepatitis. But we do not recommend that you start treating everybody. Look at TPO, look at goiter, look at family history. We'll talk more about when we talk about thyroid in the next session. But if your TPO is negative, TSH is less than 10, no need for treatment in that regards. So I think this is the last case, Dr. Sayan, 12-year-old girl.
Yeah, this is a 12-year-old girl with a height of 130 centimeter, weight of 58 kgs. So not that tall, but a weight which is on the higher side. But all the screening tests which were done were normal, and the child was reassured and sent back home. Now, this child presents to us now with rapid weight gain. So, Dr. Anurag, do you think that the child, referring doctor missed anything when the child actually presented to him?
Can you show me the growth chart in this?
Yeah, this is the growth chart.
As you can clearly see the growth chart, this is a short and plump child. So we should work out for the endocrine and causes in this child.
The endocrine, the investigations which were done on referral showed a slightly low TSH with a normal FT4.
This thyroid profile is probably normal. So most probably this is a case of Cushing syndrome. We should do look for Cushing syndrome in all these short and plump child also.
This is the picture of the child, sir, when she presented to us.
The clinical picture is also suggestive of the Cushing syndrome. So we should go for overnight DEXA suppression test in this child.
So, sir, overnight dexamethasone suppression test was done, and it came out to be 154 nanomoles per liter.
So this is not suppressed, and so this is a case of Cushing syndrome.
Yes, sir. Thank you for this wonderful message. A short and plump child needs to have a workup for endocrine causes of the same. And when clinical features match, we should go according to the clinical features.
So I think this is the last case. Now, Riddhi, this is a higher child who is 3-year-old with rapid weight gain. Weight is 26 kilograms. And there is severe hyperphagia which was present since birth. What do you think we should be doing here, Dr. Riddhi? The basic workup is normal.
Yes. So here in this case, actually the girl is less than 5 years of age. So early onset obesity, plus there is one marker that height is also on the lower side. There is rapid weight gain and severe hyperphagia. All these pointers suggests towards a pathological cause of obesity. So we should definitely do genetic study or other parameters like leptin level, because leptin, which is most important hormone required for the satiety of the
One big message here is that there are recurrent infections which are common in leptin deficiency. So
leptin deficiency.
Yeah, we got leptin levels which were undetectable.
So this is the proven case of leptin deficiency.
So we need to be very cautious. If there is an early onset obesity, then think of genetics. So again, the big message is that in obesity, you don't need to evaluate everybody for a cause. But if they are short, early onset, there is hyperphagia, syndromic features, delayed development, vision abnormalities, you need a workup from that perspective that we found. So we have also developed a obesity interpreter, which basically uses these parameters, just simple parameters. All you have to do is to plot them and you will get what is the likely diagnosis. We have validated this, and what we found, and this is from our own clinic. So what we see, even in a pediatric endocrine clinic, 92% obesity is physiological. So if you talk about pediatrician, it will be like 98%. 7% had pathological endocrine cause and only 1% had a genetic cause. So this is from our own clinic. So this is a referral center. We are seeing this. And when we found, again, only one case had a discordant. So this app can really guide. Like this case, it guided that this could be Bardet beetle because the vision was abnormal. So it has specific inputs which uses those algorithms to make a diagnosis from that regard. So the practice points is obesity is usually constitutional. Height is the most important. In a boy with short stature, weight is most important. In an obese child, the most important thing to look at is the height. Do not treat mild elevation of TSH, and short and plump is endocrine. This is what we've been discussing, both the scenarios. So I think this was a wonderful discussion. I'd like to thank all the panelists who are part of this, Dr. Sayan, who conducted the program so well, Dr. Riddhi, Dr. Bifina, Dr. Vijay, along with that, Dr. Anurag Katia. This was a wonderful program. We'll just have a look at any questions which are there. So Dr. Syed Farooq Ali is asking about what is the cause of polyuria in rickets. Now, this child had polyuria. It was not because of rickets, but this was a renal tubular acidosis. So if you have polyuria along with rickets, think of RTA as a possibility. Dr. Bharani Anand is asking, sir, in case 7 Turner syndrome, there were clinical pointers to syndrome. Should we use Turner specific growth chart or normal growth chart? Now, this is a very important thing. Why we should use the Turner specific growth chart if we want to look at whether there is an additional cause of growth failure. In normal chart, Turner girls will be short. In Turner chart, they should be normal. But if you wait for them to get below Turner chart specific one, you will be too late. So the treatment recommendations are height, which is below the 5th percentile by the normal growth chart. And even the Cincinnati growth lines, what they say is that if there's a high tendency of having short stature, you start treatment. You don't wait. So you look, actually, you plot on a normal chart. Now, how much growth can be expected in Turner syndrome with growth hormone? Very relevant. When you treat with Turner syndrome, the expected response is not as good as GHD. You expect 1 centimeter per treatment year in terms of benefit, which is there in Turner syndrome, which is there in that scenario. Dr. Priya is asking when to start growth hormone therapy, when to stop growth hormone therapy. So growth hormone therapy, very importantly, should be given only when there are specific indications. There are 3 basic indications, I would say: growth hormone deficiency, SGA, Turner syndrome. Others are rarer, like Prader-Willi syndrome, Noonan syndrome, or idiopathic short stature. There are specific guidelines. You have to prove growth hormone deficiency. That is one. Second, Turner's or SGA you can treat. SGA, ideally, you can start after 4 years. The treatment should be continued till the height is there. So the bone age, if we have got reasonable bone age, you can use it till that perspective. So these were the specific questions. I think we'll also look at the practical scenario of growth hormone in familial short stature. So if there is a familial short stature that fits into idiopathic short stature, there what you need to understand is that the response to growth hormone is limited. You do not expect huge response, 3 to 5 centimeters at a very huge cost. So what I will suggest is give a course of growth hormone for 6 months. If the height is increasing, continue. If the height is not increasing in that scenario, you would need to probably stop therapy at that point of time. So I think this was a wonderful session. You can keep asking questions. We'll address it later on. I'd like to thank Dr. Riddhi, Dr. Vijay, Dr. Anurag Katia, and Dr. Bifina for being part of this panel. Thanks, Sayan, also for this regards. Now we will be moving forward with regards to the next session, which will be on the thyroid, which is a very, very important part. And what we're going to do in this one is to go forward with cases about thyroid. We'll first talk about some basic information about thyroid so that the thyroid assessment becomes easy. And then we'll go forward with regards to the cases for this scenario. And this is going to also be an interesting session that we are going to deal with in that perspective. So we'll start off with the thyroid session first. And for this session, I am joined by 4 eminent experts who are from across different parts of the country as well as abroad. We've got Dr. Sonal Shah, Dr. Seema Rai, Dr. Manisha Maurya, and Dr. Jyoti Agarwal, who are part of this program. Dr. Vibha will be joining me once we start the cases. Dr. Sonal is a professor of pediatrics at SPM Medical College, Jamnagar. She is very dynamic in terms of pediatric endocrinology and really encouraged pediatric endocrinology in the hospital. And that's a very, very, in that area, the whole area of Jamnagar, pediatric endocrinology is really taken up in terms of the overall teaching as well. Dr. Seema Rai is associate professor with extensive teaching experience. She is at Faridkot, and her area of interest include endocrinology as well as oncology. Dr. Manisha Maurya is a faculty at Allahabad in the MNMC Motilal Nehru Medical College in Prayagraj, and she has keen interest in the field of pediatric endocrinology. And Dr. Jyoti is part of the BP Koirala Institute of Medical Sciences, Dharan in Nepal. So we are really pleased to have all the 4 experts regarding thyroid in that perspective. Before we start with cases, we'll quickly go through a basic overview of the hypothalamic pituitary thyroid axis, which basically determines the overall evaluation and presentation. So we all know that the most important regulator is the TRH hormone, which regulates the production of TSH, which then stimulates the production of T4, which is a primary product from the thyroid. Now, from this T4, we have peripheral conversion of T4 to T3 using the monodeiodinase activity type 1, which is then bound to the thyroxine binding globulin. So around 99.7% of T4 and 99.7% of T3 is bound to TBG. So only 0.03% and 0.3% is actually the free form, which is the active form. So the level and the function of thyroid hormone not only depends upon how much you have T4 and T3, but also how much is the thyroxine binding globulin. So conditions which increase or decrease TBG level will have an effect on the overall thyroid functions and assessment in particular. Then thyroid really acts and then it causes suppression of the TSH level. So the first thing to happen in a primary hypothyroidism is the rise which happens in TSH. Next step is that you will have a fall in T4. But once T4 becomes very low, T3 will not fall quickly because body will like to compensate. So the most useless investigation in a child with suspected primary hypothyroidism is T3. So we do not recommend routine T3 evaluation in hypothyroidism. While if we talk about central hypothyroidism, you would expect that you will have, of course, a low TSH with a decrease in the level of T4. But remember, often in central hypothyroidism, you may have bioinactive TSH which comes in. So the TSH may be falsely high up to 20 also. So if your TSH is below 20 and FT4 is low, think of a central hypothyroidism. And finally, in thyrotoxicosis, the most important thing will be, the first thing will be TSH will come down, then your T4 will go up. But remember, because monodeiodinase activity, if it is more, especially in iodine deficiency, the T3 level may rise more. So T3 is very relevant in thyrotoxicosis because you may have a high T3 and a normal T4. This is what is known as T3 toxicosis. So these are things which we need to understand. So in a thyroid function test in hypothyroidism, as I discussed, we have to primarily focus on TSH and T4, and FT4 and TSH will be an appropriate one because we don't want to be confused using the thyroxine binding globulin. While if we talk about thyrotoxicosis, you will need to do TSH, T4 and T3, all of them. So what we recommend is T3, FT4 and TSH. Now why I'm saying T3 and not FT3? Because the measures of FT3 are usually indirect. They depend upon FT4 only. So they are very unreliable. So for primary hypothyroidism, FT4 TSH, for thyrotoxicosis, total T3, free T4 and TSH is what is recommended. Now, TSH has got a significant variation across the day, but the variation is much lower than the biological variation. So you can do TSH pretty much at any time of the day. And for a given individual, the variation is not very huge. So if you want to do TSH, you can do any time of the day. You don't need to wait till morning, and it is not affected by whether you have taken the tablet or not. But if you are measuring free T4 and somebody has taken the tablet, half-life is short, your FT4 may suddenly go up. So do not measure FT4 if somebody has just taken the tablet. So it has to be before the tablet when you are assessing in that scenario. We all know that there is a huge surge of TRH which happens because of the cold environment exposure. So first 48 hours, the levels will be high and then they will come down. So you should ideally do either in a cord blood if you want to do a screening, or around 72 hours or more. If you are doing a bit earlier, you should actually have a different cutoff. A higher cutoff will be required in that perspective. So if your TSH is above 40 in the first week, 20, 1 to 2 weeks, and 10 beyond that, that is the time when you start considering treatment in that perspective. Children also tend to have higher level, but treatment will only be done if it's more than 10 in most scenarios. The other thing to remember is that there is a log linear relationship between a free T4 and TSH. So as soon as the free T4 goes down, TSH should go up hugely. So anybody who has got a low FT4 should have a TSH above 100, usually above 100. But even if it's about 20, I would say this is primary. But if your FT4 is low and TSH is below 20, that is, it is normal, low or slightly elevated, this could still be central hypothyroidism. This is a big message you should think, because if you have a central hypothyroidism, you do not want to miss a CNS tumor. You do not want to miss a cortisol deficiency, because if you do not treat it, you will have precipitation of adrenal insufficiency with thyroxine treatment. And if your FT4 is high, you expect TSH to be 0, that is thyrotoxicosis. Detectable TSH with a high FT4 is very rare. It is either a TSH secreting tumor or a thyroid resistance, unheard of. So don't worry about that. So if you have a detectable TSH with a high FT4, repeat it before you do something else. Otherwise, the diagnosis is pretty clear. So if you have a low TSH and a low FT4, this is of course central hypothyroidism. If you have again a high FT3 and a low TSH and T4, this is an unusual scenario. Somebody is getting T3 from outside. If you have a high FT4 and a low TSH, this is thyrotoxicosis. Even if you have a normal FT4, T3 may be high and TSH may be low. This is T3 toxicosis. So this is how you can interpret the other way around what I'm trying to do. If you have a high FT4 and a normal or a detectable TSH, this is inappropriately high. This is a rare scenario, TSH adenoma. If you have low FT4 with a normal TSH, this is central hypothyroidism. And then finally, if you of course have a high TSH with a normal FT4, this is subclinical hypothyroidism. And if it's low, it's overt hypothyroidism. So all you have to focus is TSH and FT4 in this slide, and you will get the right diagnosis, with T3 playing a role somewhere, somehow not very important. Now, how do we interpret the neonatal screening? So we should ideally do at day 3. Remember, when you look at serum levels, they are 2 times the typical blood levels. But most assays, when they actually report blood levels, they correct for this. So this is already corrected when you get the report out of it. If your TSH is more than 40, look at free T4, consider treatment. If it's less than 20, 99.9% will be in this category. No treatment is required. If somebody is having an earlier assessment, 24 to 48 hours, then you use a cutoff of 34 rather than 20. Now, if you have a borderline TSH between 20 to 40, repeat it after 14 days. If it's more than 20, so as I said, 40, 20, 10. First week 40, second week 20, then 10. So more than 20, you can consider treatment. Less than 10, no treatment. 10 to 20, repeat after 21 days. Now, if it's more than 20 now, then this is a rare scenario. This is a delayed rise. You may need to give treatment, of course. 6 to 20 is a borderline situation. So ideally, you should do a thyroid scan. And we'll discuss all these case scenarios when we keep on discussing the cases. This is just to make a theoretical basis. You do a scan and treat. Less than 6 does not require any treatment in that perspective. So very important, age-specific cutoff 40, 20, 10. This is what is very important to identify. Now, if you have premature child, somebody with Down syndrome, same-sex twin, hospitalization, you should do a repeat level on follow-up in that perspective. What about prematurity? And this is a very confusing picture because often premature individuals will have a falsely high and a delayed rise in TSH. So here, if your TSH is less than 10, then you repeat at 2 to 4 weeks or when they become term. If it's more than 10 and your FT4 is low, so if your FT4 is less and TSH is more than 10, you have to treat. If it is normal and TSH is less than 10, then you of course repeat. While if you have low FT4 and a low TSH, this could either be a central hypothyroidism, rarely, but most likely this is non-thyroidal illness, very common in prematurity. Here, look at features of MPHD. If it's there, then treat. Otherwise, it's unlikely. So the key message is, if you have clear-cut high TSH elevation and low FT4, treat. In all other situations, be careful because this could be non-thyroidal illness and treatment may not be required in that perspective. Once you diagnose congenital hypothyroidism, you should do a thyroid scan. If it shows ectopic, this is ectopic thyroid, lifelong treatment is required. If it shows increased uptake, this is dysharmoniogenesis or iodine deficiency. If it shows absent thyroid, do a thyroid ultrasound. If it shows absent, it is agenesis. If it's present, do a TRAP. If it's present, it is a maternal transient hypothyroidism. And if it's absent, you're thinking of other rarer causes. Very important. Just because your thyroid is absent on a scan does not mean it is agenesis. You should do an ultrasound also because you can have an in situ gland which is not picking up the nuclear material. So now we'll start with the cases. Dr. Vibha, who is a fellow in our department, will now start with the cases.
Thank you, sir. So we have a first case, a 20-hour girl and was born in our NICU, and we got a reference call for this. And NICU team got an TSH done, and the TSH was 28. So, Dr. Seema, what should be the plan of action in this case?
Good evening once again. Thanks, Dr. Vibha, for this question. Now, we have a 20th hour of life for girl child with a TSH of 28 milliliters per liter. So let us have the perinatal changes graph and see whether this investigation should have been ordered, and if at all it has been done, what should we do now? These are the changes in the term, the red line showing in the term changes, and the dotted green is showing in the premature. At birth, there is surge in the thyroid hormone because of suddenly the baby is coming from intrauterine to extrauterine life and prone to hypothermia. So thyroid hormone surge acts as a non-shivering thermogenesis, and this acute and sharp rise comes down by third day and start continuing falling down till third week of life. So ideally, this should have been done in the cord blood or after 72 hours of life. So this we have to repeat, and we repeat it on 14th day with FT4 and TSH. The FT4 was 1.28 nanogram per DL and TSH is 8 milliliters per liter. So the key messages for this patient is, ideally, the screening for the congenital hypothyroidism should have been done after 72 hours. Within 72 hours, the cutoff is 34 milliliters per liter as per I-PPEC guidelines. So this the newborn require further screening. If this is still between the 6 to 10, we'll see in the future cases. This is the key message that the screening should be after 72 hours, not within 72 hours.
Thank you, Dr. Seema. The key message is very rightly given. So it is very important to screen the TSH after 3 days of life because of the TSH surge. So here's the next case. We have a day 4-old child with a TSH of 22. And when we have repeated the TSH at the day 14, it dropped down to 12. Then we again repeat it on the day 21, it dropped down to 9. And the free T4 was normal. So Dr. Sonal, what should be the plan of approach in these type of cases?
Yeah. Good evening, Dr. Vipa. Yeah, as we have a child who was screened on day 4 with TSH of 22, and as we have rightly seen, like if the TSH level is between 20 to 40, it has to be repeated after 2 weeks. And as shown in this case, it was after 2 weeks, it was 14. So again, as we see the chart, if it is after birth, if it is more than at the age of 4 days, if it is more than 40, you have to start the drug. But if it is between 20 to 40, you have to repeat it after 14 days. And again, if it is more than 20, you have to start the treatment. But in this case, it was between 10 to 20 at 14 days. So we are supposed to repeat it after 21 days. And after 21 days, it was around 6 to 20. And the FT4 was normal. But still, the scan is indicated because it is at 3 weeks also. The child is having a TSH of 20. It was between 6 to 20. So TSH scan showed hemiagenesis of the thyroid gland. And even if the FT4 is normal, we have to treat the child. But if it is less than 6, there is no treatment is required. So all the cases of hypothyroidism, congenital hypothyroidism, we should go for thyroid scan and see for the hemiagenesis. So key
what messages would you like to give?
Pardon?
What key messages would you like to give from this case?
Key message is that if the TSH level at day 4 is between 20 to 40, you need to repeat at 14 weeks, 14 days of life. And again, if it is between 6 to 20, then again you need to again repeat at 3 weeks and do the thyroid scan if it is between 6 to 20 at 3 weeks.
And thank you so much, ma'am, for the key message. And definitely, if the TSH is between 6 to 20 weeks, there is a need of evaluation. We have to go for the scan. And if there is a hemiagenesis, we have to go for the treatment. Now, the next case, we have a day 10 child with a TSH of greater than 10. So, Dr. Jyoti, this is, and the FT4 is 11, and the nuclear scan showed no thyroid tissue. So, what should be the plan of action in this case?
Thank you, Dr. Diva.
And how would you like to manage this case?
So, we should, in this case, the plan of action should be to start the drugs as soon as possible, to start the thyroid hormone. We shouldn't delay the treatment beyond 2 weeks of life, because that can lead to developmental and neurological sequelae. And levothyroxine is the drug of choice. There is no role of there is no better role of T3 over T4. And we should stick to the specific brand, as different brands have variability of thyroid hormone, and tablets should be given because syrup is in the unstable form, and the dose should be 10 to 15 microgram per kg per day, and the lower doses should be used for dyshormonogenesis and higher doses for dysgenesis. And the time.
How should we follow up the case, and what should be the dose titration?
So dose titration can be based on free T3 level, T4 level. So in this case, since free T4 level is 10 picomole per liter, so we should start the dose at 8 to 10 microgram per kg per day, and we should titrate accordingly.
And this is a very important message which Dr. Jyoti is giving, is that we should actually look at the FT4 level before we start treatment. Generally, we say 10 to 15, more than 15. But if it's very low, start at a high dose. And your aim is within the next 2 to 4 weeks, your FT4 should be high. It should become supraphysiological. We don't want to be slow. So that is why, based upon FT4, we have to titrate the initial dose. So on follow-up, this patient...
And on follow-up, the free T4 was high. So what should we do, ma'am, now?
So if on follow-up, free T4 is high, then we have to reduce the dose, and they would have been something would have went wrong in this case, because initially in the initial scenario there was thyroid scan does not show the uptake, so we should go for the ultrasound. And this could be a case of apparent athyrosis, because child dose has been reduced and the child is off treatment, so this could be a case of apparent athyrosis. So we should try to follow the approach. So here the thyroid scan has been done, so the thyroid scan does not shows the uptake, so we should go for the thyroid ultrasound. And on thyroid ultrasound, if there is no thyroid gland, then that's agenesis. So this could be a case of TSH receptor antibody that would have crossed transplant placentally, because mother would have been hypothyroid. So I think this could be because of the presence of TRAB.
So, ma'am, what key message would you like to give from this case?
So all absent uptakes are not agenesis, as shown in the approach, and we should always confirm if this is a true or apparent athyrosis by the ultrasound.
Thank you so much, ma'am. This is very important that we should not go up only by scan. If scan is showing no thyroid, it doesn't mean that there is no thyroid. We should always go for ultrasound, because as we all have seen that if scan is showing no thyroid, it could be the case of agenesis, or it could be due to the maternal TRAB antibodies. So now moving towards the next case. Now we have a day 4 child with a TSH again with greater than 100. And he was diagnosed with dysharmonogenesis. So Dr. Manisha, he was treated with levothyroxine of 50 microgram. And after 4 weeks, his free T4 was 21 and TSH was 24. So ma'am, how should we titrate the dose in this case?
Good evening, everyone. I would like to, at the onset, I would like to thank Dr. Anurag Vajpayee sir for inviting me as a panelist. Dr. Vibha, since this is looking like a...
Your video is off.
Sorry, sir, there is some technical problem.
Okay, no worries. Please go ahead.
Okay, sir. Sir, since this is a case of dysharmonogenesis and the treatment was started with thyroxine, and as we can see that FT4 has come to the normal range, but the TSH is still in a high range. But in this scenario, if hypothyroidism is there for a long time, since this is a congenital hypothyroidism, TSH may remain high for around 6 months to 1 year. So there is no need to increase the dose of thyroxine which we are giving in this child. And the dose titration in congenital hypothyroidism, which has to be done as discussed earlier by sir also, that initially first we have to monitor the child. If we start with the thyroxine hormone at 2 weeks and then 4 weekly, till we are able to maintain the target of FT4 to a higher normal range and TSH towards the normal range. But TSH in congenital hypothyroidism sometimes may remain high for 6 months because of the reset of HP, hypothalamic pituitary axis. And this reset of HPA axis may persist till 6 months to 1 year. And in this table, we can easily see that if TSH is high and FT4 is low, we have to increase the dose. If TSH is high and FT4 is normal or high, as is seen in this case, we have to continue with the same. If TSH is normal, FT4 is normal, continue with the same. If TSH is normal and FT4 is high, we will continue with the same treatment. So in this case of dysharmonogenesis, Dr. Vibha? Hello?
Dr. Manisha, you're audible. You can continue.
I think the screen is not there. I'm not able to see the screen which is there. Is there something, is screen is visible to you, Dr. Weber? Hello?
It's not visible to us also.
So if in case of dysharmonogenesis, what we have to do, we have to maintain the target of FT4 towards a higher normal range and T4 to the normal range. So we will continue with the same treatment.
Yeah, sorry for this technical glitch. There was some issue. Now we are back. So Dr. Manisha really clearly pointed out that the most important thing to look at in this scenario is to look at the TSH as well as T4 level. Now, what we expect in this scenario is that initially T4 should go in a high normal range. We want the FT4 to go into the double range, and then we follow up on TSH. What is important to remember is that TSH may take time because there may be a reset axis of the hypothalamic pituitary axis. So if your TSH is high and FT4 is low, you have to increase the dose. While if your FT4 is normal high, still you continue the same, because this could be a scenario where the HPT axis is reset. This is what Dr. Manisha talked about. While if your TSH has gone low, you have to reduce the dose. So the most important parameter in the first 2 years of treatment is actually the FT4 and not the TSH in that perspective. So now this was the case we were talking about. On thyroxine treatment, there was a high FT4 and a high TSH, and Dr. Manisha nicely said that in this scenario, you
Yes,
should continue the same dose.
Continue with the same treatment.
And this girl again came at 3 years of age with a delayed speech. So, ma'am, what could be the cause of this delayed speech in the same?
Dysharmonogenesis and congenital hypothyroidism is usually may be associated with the Pendred syndrome, in which there is defect in Pendrin gene. And this is associated with a sensorineural hearing loss. So every child with congenital hypothyroidism, we have to screen the hearing at 3 months of age, so that the sensorineural hearing knot may not be missed. In this case, maybe sensorineural hearing loss persisted in this child, was present in this child, and which could be the cause of delayed in speech. So as we can see in this diagram, that Pendred syndrome, this harmonogenesis can be associated with epiphyseal dysgenesis, some developmental problem in hearing assessment. So we have to always screen for the cardiac and the hearing defects in a child with congenital hypothyroidism. So the key message is that there could be a reset of HPA axis in long-term hypothyroidism, for which the TSH level may remain high for long time. So we have to titrate based on the free T4 levels, and we have to screen for the hearing early at 3 months of age.
Thank you so much, ma'am. Now moving towards the next case, we have a 32-week-old neonate under the routine screening done by the NICU team, and they found the TSH was 7 with a normal free T4. So, Dr. Sonal, what should be the approach in these type of cases?
Yeah, since this is a preterm child, you may expect little variation, little low TSH. Other causes of low TSH are during the illness, Down syndrome children. So whenever we have a preterm child who has been screened and found to be having TSH low, you should not take the TSH within around 7. We should not take it lightly. And if it is like, the approach should be, if it is more than 10, we should do the free T4 level. If free T4 level is low and TSH is more than 10, it is most probably, it is primary congenital hypothyroidism, and you should start treatment as early as possible. But if it is less than 10, and if it is more than 10, and if you do free T4, if free T4 is low, as Anurag sir has already mentioned, TSH is less than 10, it may be a part of multiple pituitary hormone deficiency, and you should do MRI, and it may be a central congenital hypothyroidism. And if it is less than 10, ideally we should repeat it at 2 weeks or when the patient achieves the term. That should be the approach. And if the TSH, if TSH is, in this child it was found to be 14, so we must start the treatment. So the key message here is, in preterm children, you have a delayed rise in TSH level. You may not get the real scenario of the hypothyroidism when we do the neonatal screening around 72 hours of the life. So if you have this condition, we must repeat screen at 2 weeks or when the baby has achieved the term. So that is the key message.
Very nicely put, Dr. Sonal. So, Dr. Vibha, what are the other conditions other than prematurity where you like to repeat a screen?
Sir, trisomy 21, same-sex twin in the hospitalized child.
Yes. So if you have same-sex twin, there's a chance of twin-to-twin transfusion. That's why you may have a falsely low level, and also in somebody who has Down syndrome and, as you said, hospitalized. So this is very important from that regards. Now we'll go a bit about acquired hypothyroidism. We should consider acquired hypothyroidism if somebody has variety of manifestations like growth failure, pubertal disorders, both precocious and delayed puberty, cardiomyopathy and pericardial effusion, hyponatremia, motor developmental delay with high CPK and PCOS. So thyroid is very common across these scenarios. You have to evaluate and assess in that regards. Now, very importantly, you can also see dyslipidemia, high CPK. So often children are diagnosed as Duchenne's and they turn out to be a scenario of hypothyroidism. Hyperprolactinemia, which turn out to be hypothyroidism. Anemia, hyponatremia. So pretty much thyroid becomes very important to evaluate in that perspective. So now how do you approach? The most important tests are two: free T4 and TSH. So if your FT4 is low and your TSH is about 20, this is primary. Very easy to diagnose. Below 20, think of central, do an MRI and cortisol. If it's normal, look at TSH. If TSH is below 6, 6 is the cutoff for adolescents, it's normal. More than 10, consider treatment. If it's 6 to 10, look for risk factors, which are basically TPO positivity, goiter, and a female gender. If they are there, consider treatment. Otherwise, follow up. So very importantly, there is no need for routine treatment of anybody who has a borderline TSH elevation in that scenario. Now, how much dose to give? It's basically higher dose because it's body surface area based rather than weight. So at younger age, you need a higher dose, and the adult dose typically goes to 1.6 microgram per kg per day. So roughly, if you talk about 100 microgram per kg per meter square per day, that will be the reasonable dose of hypothyroidism. Remember, in acquired hypothyroidism, we do not want to rush treatment. In congenital, because if you are not able to achieve your FT4 level in the first 3 weeks of life, you are dropping IQ points. There you have a rush. Here, if you start at a very high treatment, what problems will happen, Vibha, in that scenario if you treat too quickly?
So the child will develop headache, irritability, will not able to concentrate in classes.
So you will have a tendency of benign intracranial hypertension, slip capital femoral epiphysis, early puberty. And this is what Vibha is studying, is what is the impact of hypothyroidism on height. Puberty may happen early if you treat very quickly. So all this has to be evaluated before you do. So you start at lower dose, especially in severe cases. And very importantly, do not give it with calcium or iron, where you can have a thing, or soy protein. Do not expose the medicine to light. That is why all these medicines are in a black container usually in that regard. So we'll start now with the cases again.
So now moving towards the acquired hypothyroidism, we have a 12-year-old girl who came to us with a complaint of increasing weight, and her height was 156 centimeter and weight was 56. There was no other clinical features, and her TSH was 6.4. And she was advised levothyroxine. So, Dr. Seema, it is judiciable to treat this patient with levothyroxine. What is your point of view in this case?
Thanks, Dr. Weber, for the case. Now we have a child, 12-year-old, whose weight is 60 kg and height is appropriate. Now let us have a look. Obesity means we have more adipose tissue in the body. Now this is very much proven in the studies that adipose tissue acts as an endocrine organ. So it secretes leptin, which is a neuroendocrine factor, which stimulates the paraventricular cells in the hypothalamus, secretes TRH, which further stimulates TSH. So the obesity will, because of the leptin increase, will lead to high TSH, but this will not be as high as in the pathological causes. This high TSH with normal T4 and normal T3. So the obesity induced increase in the TSH is the result of the obesity. This TSH does not lead to obesity, and this is pure compensatory, entirely reversible with the management of obesity and no treatment required. Let's have a look on the flow chart, how we'll approach such cases. This flow chart is showing we should, if the FT4 is normal, TSH will look, here in our case, it was 6.2. So you should treat if there are risk factor present, like if there is a TPO positivity, if there is goiter, if there is a family history of hypothyroidism, and if there is girl child. In this case, in our case, no other clinical picture was there, no goiter, FT4 was normal and TPO negative. Hence, this patient did not require any treatment. And this borderline TSH is just because of the obesity to increase the BMI, because thyroid hormones are catabolic. So just as a result of the obesity, this TSH is rise, does not need treatment, and toxin should not have been required. Only the weight management, lifestyle modification for obesity is required. So the key message is border high TSH is the effect of obesity, not a cause of obesity, and we should treat obesity. And no treatment is required below 10, and we should treat the obesity, not the L-toxin, not the TSH report.
Thank you, Dr. Seema. Very nicely said by Dr. Seema that we should not treat all the obese children with TSH, just slightly high TSH, that is borderline elevated TSH like 8, 9 or 10. So moving towards the next case, we have a 10-year-old girl who came to us of complaint of poor concentration in the class. Her height was 136 centimeter and weight was 34 kg, and she was euthyroid. Her TSH was 2.4 and T4 was 16 nanogram per dl, which is lower than the normal limit. So, Dr. Manisha, what do you think? Is it really hypothyroidism, or what's wrong in this case?
Dr. Vibha, I think since the height and the weight and is within the normal range, and the child is in euthyroid, and there is TSH is normal, there is mild decrease in T4 level. T4 level depends, we have to do a free T4 level because the thyroxine binds to the thyroxine binding globulin, albumin, and the transthyretin. Most of the thyroxine is bound to the 75% is bound to the thyroxine binding globulin, and this the conditions which may, as told by sir also, some conditions may increase the TBG level and some condition may decrease the TBG level, and this will interfere with the levels of thyroid. So the condition which decrease the TBG level, the total T4 level may be low. So if we have a child in which if who looks seems to be normal, euthyroid, but T4 is in the lower normal range, we have to get a free T4 level.
As we can see, the free T4 was in the normal range, 12, and TPO was negative.
TPO was,
so,
yes.
ma'am,
so we don't need treatment at present, since both the TSH is in the normal range and FT4 is the normal range. So the
message you would like to give?
We always have to, although T4 is a good valid method of doing the thyroid assessment, but if we are getting T4 in a lower range, then we have to confirm hypothyroidism by doing free T4 level, because T4 depends on the thyroxine binding globulin and albumin, and the conditions which increase or decrease these binding globulins may cause error in the estimation of thyroid assessment. So we always have to do a free T4 level.
Thank you, ma'am. It is very important to do the free T4 estimation in every case. Now, moving towards the next case, we have a 12-year-old girl who came to us with a complaint of lethargy, not taking interest in any activity. Her height was 140 centimeter and weight was 36 kg. Her free T4 level was 6, which is lower than the normal limit, and TSH was 12. And so thyroxine was given for the treatment. So Dr. Jyoti, is giving thyroxine is the right thing, or is anything missing in the approach? What would you like to say?
Thank you, Dr. Viva. So seeing on to the linear relationship of free T4 and TSH level, since the free T4 level is very low, TSH must be very high, but your TSH is only 12. So in this case, we have to think of central hypothyroidism rather than starting with the thyroxine. So we have to evaluate in the line of central hypothyroidism. So
And for this, we get the cortisol done and it was low. And for this, we get the MRI done and there was empty cella. So for this, what should be the treatment?
So we have to think in if this is a case of central hypothyroidism, the most common cause of central hypothyroidism is multiple pituitary hormone deficiency. So we have to send anterior pituitary hormone assessment, and since MRI is showing empty cella, so we should not start thyroxine initially. We should start hydrocortisone. Followed by that, we should start thyroxine. As if we start hydrocortisone before, it will unmask cortisol level, and the child may go into shock.
So, Dr. Vibha, which enzyme does thyroxine stimulates, which causes this precipitation of the adrenal insufficiency?
Sir, 11 beta HSD.
So 11 beta HSD2, so which will inactivate the activity. So it will basically inactivate cortisol, and that's why you will have a problem in that scenario. So very important, if you're thinking of a central hypothyroidism, you have to do a MRI before that, and in that scenario, you also have to look at cortisol and treat appropriately in that perspective. So the key messages, Dr. Jyoti?
So when the T4 level is less and TSH is not as high as expected, that is less than 20, we have to think of central hypothyroidism. And in those scenarios, we have to go for MRI imaging, and anterior pituitary hormone assessment should be done.
Thank you, ma'am. Very nicely said that we should get the cortisol levels done to avoid the adrenal crisis, as sir has said. Now moving towards the next case, we have a 12-year-old girl who came to us with a growth failure. Her TSH was greater than 100, but the free T4 was 6, which was very low. So, Dr. Sonal, how should we start the treatment in this case, and how should we do the dose titration?
So this is a clear-cut case of hypothyroidism, most probably acquired hypothyroidism. And since the child has also presented with growth failure, it has to be a long-standing hypothyroidism. So dose for more than 10 years will be 2 to 4 microgram per kg per day. But we don't directly start with a high dose. We usually start with a lower dose because, as you rightly mentioned, that if we start with the higher doses in case of a long-standing hypothyroidism, it might lead to headache and signs of raised intracranial tension. So here we have to start with 25% of the calculated original dose, and then gradually we have to increase the dose. Again, one thing we have to explain to the patient is timing of the drug, because timing of the drug is very important. Child has to take the drug on empty stomach, and child should take the calcium and iron preparation after 6 hours of taking the thyroxine tablets. The thyroxine tablet, how to preserve is also very important, because they should keep it away from the sunlight, direct sunlight. And they have to avoid the high soya protein diet along with when they take the thyroid medicines. So timing is very important, dose is very important, and the timing of the other drug, taking of the other drugs is also very important. So this message should be passed on to each and every parent or the child.
Now again, ma'am, after follow-up of 1 year, the same patient came to us with a TSH of 23, and she came with a report of free T4 of 26.
Yeah.
So what, according to you, has gone with this report? Is it really?
Yeah. So since TSH is 24, it is definitely high, but free T4 is normal. So in these circumstances, it might have occurred that we have to check the adherence of the whether how much tablet, because it might have occurred the child might have swallowed 5-6 tablets or 10 tablets before taking out the report, because she wanted to avoid, because it's a typical adolescent child. She wants to avoid the she wants to be cured of the disease, and to hide this thing, she might have taken the higher dose. So we have to check the dose and other things when we get this kind of, we have to check the compliance, we have to check the dose, and the usually how do we check it? Like usually we repeat TSH every 3 monthly and FT4. And depending on the TSH and FT4 level, we increase or decrease the dose. So if in this case, it was a high TSH and it was a high T4 level, so we have to check the adherence. As I explained you, a patient might have swallowed many tablets. If it is TSH is high, but normal T4 is normal, you have to continue with the same dose. But if it is TSH is high, but FT4 is low, then you have to increase the dose. Now, if TSH is normal, FT4 is normal, again, you have to continue with the same dose. If TSH is low and the T4 is high, then definitely you have to reduce the dose. And again, we have to highlight that because being a teenage girl, you have to recently, because FT4 is affected by the recent intake of the drugs, so that we have to check for it. So key message here, yeah. It has to be, when we start the thyroxine treatment, it has to be in a long-standing hypothyroidism, except in case of congenital hypothyroidism, where we have to give it within first 14 days of the life. But here, a high dose, but here we have to gradually increase the dose. We start with 25% of the original dose, and then we gradually build up with the dose. Timing of the drugs, empty stomach, and compliance or adherence to the treatment is very important.
Thank you so much, ma'am.
And Vibha, what is the difference in half-life? Because this is a very important question from here. What is the difference of half-life of TSH and T4?
So
Which has got a longer half-life?
So this TSH is longer.
So TSH takes up to 6 to 8 weeks to stabilize. So that's why if you take a lot of medicines now, your FT4 will go up. It has a shorter half-life, but TSH will not go down. So this is what the big confusion is. High FT4, high TSH adherence. Very nicely said by Dr. Sonal as well. So now the next important issue is that often we are referred as endocrinologists about scenarios in which thyroid reports are unusual, but then we don't need to know whether it's really because of a thyroid disorder or something else. So in a sick child, you can have a lot of variations which may happen in the ICU. So the key message is, do not do a thyroid function test in a sick child unless it is essential. If you do a free T4 and TSH, do not do T4. And you can then look at T3, T4, which causes confusion. So I'm not going to too much in terms of physiology, just key messages. So what you expect is that TSH will be lower, because when you are sick, your cortisol will be high. It will suppress your TSH. TSH will become lower. Assessment is the same. It is not the problem in terms of assay, but you will have a falsely low TSH level. So you may diagnose somebody as central hypothyroidism, or you may miss a primary hypothyroidism. Now, if your levels are more than 10, you are still worried. If it is very low, you are worried. So you have to be very, very careful when you look at TSH. What about T4? The T4 level is also low because your monodeiodinase inactivating activity becomes more. If somebody is sick, the body says, okay, I do not want the increased activity. I want to cut down on the T4 level. It also goes down. TSH is also low. You will assess lower because your assays have a problem in assessment. So you will overdiagnose hypothyroidism in this scenario. So low T4, low TSH, central. Often people will say this is central hypothyroidism. So you have to track it. Don't go by single value in that scenario. FT4 again will be low to a lower extent because TBG is also affected. That's why your total T4 is worse. In this scenario, again, it's not very significant. We don't want to do FT4 routinely. What about T3? Again, T3 will be low and you will have a problem. So generally, all thyroid tests that you do in a sick child within the ICU will be mired by problems. They will be on steroids. They will be on dopamine, which inhibits TSH secretion. They will have stress. Body is trying to conserve energy. So this is important. So how do you interpret? So if you do not have to do testing, do not do it. Otherwise, do both FT4 and TSH. If your TSH is very low, in that scenario, look at free T4. If you have high free T4 and low this thing, this is of course thyrotoxicosis. As I said, FT4 can come down, it will not go up. High FT4, low TSH, very rare. Hyperthermia, tachycardia, cardiac failure, then you will think of it, but this can happen. If your FT4 is normal, don't worry, this is a normal scenario. If it is 0.05 to 0.3, look at cortisol level. If your cortisol is low, it means it is a multiple pituitary hormone deficiency. But if your cortisol is high, That is a normal phenomena. High cortisol suppresses TSH, so nothing to worry. If your TSH is normal and everything is normal, nothing to worry. This is a normal scenario. If it's 4.5 to 10, again don't treat, repeat after 1 week. More than 10, we talked about that this is underestimating primary hypothyroidism, but still your TSH is more than 10. This requires further evaluation, FT4 low treat, normal repeat. So look at specific cutoffs for illness. Otherwise, you will be unnecessarily treating somebody who doesn't require treatment, and that may cause worsening in that scenario. So we'll go into this case now, Vibha.
So we have a 10-year-old boy who was admitted in PRC for meningitis, and his TSH was 0.1 and his free T4 was 6. So Dr. Seema, what should be done in this case when you got a call from the PIC? What should be the plan of management?
Ideally, thanks for this case, Dr. Vibha. Sir already has explained, in ICU, you should ideally avoid thyroid hormone assessment. If at all it has been done, how to interpret this? The TSH is very low and the free T4 is also low. So looking at this graph, if everything is low, it looks like it is central hypothyroidism. But we should look at the cortisol level. Cortisol is a stress hormone, which should increase in all the stress. The meningitis is lots of stress on the body. Cortisol is high. So our cortisol is high. So it is a normal response of the meningitis to the patient. But if the cortisol is low, it indicates multiple pituitary hormone deficiency. So this case is all the thyroid, TSH and FT4 is low with a high cortisol. This high cortisol is suppressing TSH and further T4. This is non-thyroid illness. And if at all if TSH and T4, if it should be done if the patient has persistent hypothermia or bradycardia, because sickness leads to tachycardia, not bradycardia. The key message is we should avoid assessing thyroid hormone in the sick patient, and it is a completely non-thyroid illness. We should repeat when the patient improves after 2 weeks.
So I think this is a very important message which has been given in this scenario, that we should actually be looking at, it's very, very important that we will be looking at in this scenario of not doing unnecessary workup.
We apologize for the technical glitch.
So sorry for the confusion. There was some technical glitch. So we were talking about thyroid in the non-thyroid illness and how it is very, very significant in terms of evaluation and management and how there could be confusion. So ideally, we should not be using the thyroid assessment in this scenario. And if at all we are looking at, we have to look at other parameters as well, particularly with regards to the TSH levels and the free T4 levels, which are also there in that scenario. So we have discussed about congenital hypothyroidism, about acquired hypothyroidism, acquired non-thyroid illness. The next scenario which we'll discuss is about thyrotoxicosis, which is again a rare scenario which is seen, but we have to be cautious about thyrotoxicosis because this can have significant implications which are there in that regards, and we have to be careful in terms of assessment and management. So anybody who has significant weight loss, other features of sympathetic excess like tremors, eye signs, periodic paralysis and polyuria, these are the scenarios where we have to think of a possibility of thyrotoxicosis. In this scenario, we should think of nuclear scan. But if somebody already has a goiter or an eye sign, the nuclear scan may not be required. In this scenario, if the uptake is increased, we can look at solitary nodule in which one nodule has having the uptake. If it's a diffuse uptake, it will be Graves. If there are multiple areas of uptake, this is toxic MNG. And if it is decreased uptake, very importantly, this could be a thyroiditis-like scenario in which we do not need extensive evaluation, assessment, or management. So very importantly, we need to look at the nuclear scan, and then based upon the finding, we can identify. Why do we need to identify thyroiditis? Because this scenario does not require treatment and we can manage them effectively, and they will follow up, will give you a good picture in that regards. So Dr. Vibha, we can continue from there.
So we have a day 12-old child who came to us a few days back in our OPD with a complaint of irritability. Her birth weight was 2,800 grams and now it came down to 2.2 kg. His heart rate was 168 per minute and there was proptosis. Free T4 was quite high, 44, and TSH was less than 0.001. Her mother has Graves and she was treated with the radioactive iodine 2 years ago. So Dr. Manisha, what should be the plan of treatment in these cases?
Thank you, Dr. Weber. Dr. Weber, I think this is, we can see easily that the features of...
Dr. Manisha, you are there?
Yes, sir, I am here. Yes, sir, I am here.
Again, Dr. Manisha, are you muted?
No, sir, I am not muted. Am I audible?
Yeah, now you are audible. Yeah.
Sir, since the weight has reduced more than 10% in this child, and the features of hypothyroidism is also hyperthyroidism is also present, and the analysis shows that the baby is suffering from hyperthyroidism since FT4 is very high and TSH is very, very low. And the mother was treated with radioactive iodine, and since the mother was treated with radioactive iodine, sometimes the TRAB antibody, the thyroid receptor stimulating antibody, may persist in the body of mother for 2 years to 5 years. So the reason for hyperthyroidism in this baby could be the transfer of TRAB antibodies through placenta, because the TRAB antibody, the T3 and the anti-thyroid drug all can pass through placenta and can cause features of hyperthyroidism. If this mother would have been on hyperthyroid drugs like methimazole, then the presentation of this baby could have been initially hypothyroidism because of the effect of methimazole, but this hypothyroidism would have weaned off because methimazole, the half-life is only 2 days. So in such babies, we have to do repeat the thyroid assessment at 2 weeks. If we have a history of mothers with Graves' disease who have been treated for thyroid radioactive iodine or been on treatment of methimazole, and such a child has to be treated, since all the features of hyperthyroidism is present, we have to treat this child with anti-thyroid drugs and beta blockers. And if the condition is very severe, sometimes we can also add steroid and sodium iodoptate. And this is a transient condition because this thyroid receptor antibody will go off from the body within 6 weeks. So we have to follow the child for the thyroid assessment, and we can gradually stop the treatment over a period of time. So the key message is tremor and weight loss are the features of thyrotoxicosis, as told by Sir also. Eye sign is present in Graves' disease, and the treatment is methimazole and radioactive iodine in hyperthyroidism.
So I think this is a very important message of transient thyrotoxicosis, which is often seen transient Graves' disease. 5% children who are born to mother with Graves' disease will have thyroid dysfunction. Dr. Manisha very nicely said that around half of them will have hypothyroidism, which is basically because of anti-thyroid drug. The other half will have a transient Graves' disease. We'll carry forward to the next case.
We have a 12-year-old girl with a weight loss and a complaint of tremor. Her free T4 was 34 and TSH less than 0.01. She has a thyroid swelling, but there was no eye sign. And she came to us with a tremor. Ma'am, Dr. Jyoti, what would be the plan of action in this case?
So this is the early adolescent girl with weight loss and tremor, who has, which is a case of thyrotoxicosis. Since there is no eye sign, we have to go for a nuclear scan. As sir has very well said that if there is increased uptake, we have to see if it is a solitary nodule where the uptake is in just in one of the lobe, or toxic multinodular goiter, or Graves. Or if there is a decreased uptake, then there will be tenderness is there or not, yes or no. And if there is tenderness, this is subacute thyroiditis, no, then there is chronic lymphocytic thyroiditis. So if clinically and on the basis of nuclear scan, if this is a Graves' disease, then our line of treatment is methimazole, and along with that we have to go for beta blockers, and radioactive iodine can be the second option.
So Dr. Vibha, what message will you give to the parents when you are starting methimazole? When should they immediately contact you?
So they should contact us when there is a this jaundice, or there is a this cold sore throat, because there is an increased risk of agranulocytosis in this case within the first 100 days of the.
So first 100 days, if they have a throat pain, immediately get a CBC done. If it's low, TLC is low, stop the treatment. That's a big message that you have to give on that. So clearly, as we discussed, that eye signs suggest Graves' disease. If you have eye signs and goiter, you can avoid scan. The other option of scan is a TSH receptor antibody, which also we are finding to be quite effective in children to identify Graves' disease in that scenario. Next case.
We have this 8-year-old boy who came to us with just thyroid swelling. So, and it moves with, on examination, it moves with tongue movement. So, Dr. Sonal, what should be the approach in this case?
Yeah, since it is a swelling in the thyroid area and it moves with the tongue movement and the deglutition, it is most likely to be thyroglossal cyst. And here we don't require any like medical line of management. We have to straight away advise for the surgery to this child. So key message here will be that it moves with the deglutition and the protrusion of the tongue.
And this is a very high risk of malignancy also, infections and malignancy. So thyroglossal cyst requires immediate removal.
Now coming to the last case, we have a 10-year-old girl who came to us with a thyroid nodule, and she was euthyroid, and the TPO was negative, and she was reassured and was sent back to home. So is it, and there was a history that swelling was increasing day by day. So Dr. Seema, is it right to for her to send back to home because she was euthyroid, or should we done anything else in the plan of management?
Thanks, Dr. Vibha, for this case. As we are seeing that patient developed rapid growth. So this rapid progression is the high risk for the malignancy. So we can see that the right side, there's a huge lobulated swelling is there, which is rapidly progressive. Although the thyroid status and TPO suggest autoimmunity. For the malignancy, what pointers we should keep in mind? If the size is more than 1 centimeter, if the swelling is fixed to the surrounding structure, if there are the cervical or submental or the inguinal lymph nodes are enlarged, if there is a history of low dose radiation over the prolonged time, or there is a family history like RET of genes are present in the men too, if all these risk factors are present, there's a high chance this patient will have malignancy, and we should have gone for ultrasound of the neck and for further scan to see the calcification, the rim, rest of the feature on the scan, as well as ultrasound, and if the size is more, finally FNSC guided histopathological diagnosis should have been done.
Thank you, Dr. Seema.
So I think this is a very important message. Thyroid nodules in children are very, very significant because they can be markers of malignancy. And if you look at it, there will be a significant risk of malignancy of around 8 to 10% in children, especially if it is euthyroid, if your TSH is normal, if it's a fixed one, if it's more than 1 centimeter, you have to start thinking of a possibility that there could be other things that you have to look at because there can be problems. I'd like to thank at this point of time Dr. Seema, Dr. Sonal, Dr. Jyoti, and Dr. Manisha Maurya, all for joining us and enlightening us with various aspects of evaluation and management of thyroid, and Dr. Vibha as well, who, despite her being a bit sick, was able to join us and continued with that. Thank you. We'll see if there are any questions which are there. So thanks a lot. So Dr. Bharani is asking, in meningitis, is there a Waterhouse-Friderichsen syndrome, the cortisol level will be low, how to interpret in those situations? So that would be a difficult scenario. So if you have a cortisol levels which are very, very low, in that scenario, whether your FT4, and that will be a very rare possibility in a central hypothyroidism to also develop a Waterhouse-Friderichsen syndrome. So I think in that scenario, the first priority will be to correct your hydrocort. First thing you will give is to give hydrocort and then go forward from there. The next is from Dr. Fahimida, who is asking what is the perfect follow-up schedule for transient hypothyroidism. So transient hypothyroidism, 90% of cases are usually permanent, especially if your FT4 is very low to begin with. But if you have maternal TSH receptor antibody, it may cause transient hypothyroidism. Usually, in our experience, by around 6 months or so, your requirement will come down dramatically. So typical follow-up pattern for a congenital hypothyroidism is that you need to monitor levels after 2 weeks, then every month for the first 6 months, every 2 months for the next 6 months. This is how we follow up. And if your TSH is consistently going low, you keep on decreasing the dose. Otherwise, we want to continue till at least 2 to 3 years in that regards. Next question is from Dr. Sajida Abdullah, who is saying if nephrotic syndrome TSH is 9 and FT4 is 1, what should be done? So in this scenario, you are dealing with a borderline situation. So I'll probably wait and watch without giving treatment. I've seen a lot of confusing scenarios in nephrotic syndrome. Hypothyroidism is known as a cause of nephrotic syndrome as well. But I would be a bit cautious. Look at autoimmune status, TPO antibody, and follow-up will be a better scenario in that regards. Dr. Linda is asking, if the thyroid becomes a malignancy, then what do we do? So this is important. So of course, anybody who has a size more than 1 centimeter, has an associated lymph node, has a fixed nodule, you get a FNAC. Then we already discussed that there are various NIH criteria which talk about that. So if you have likely malignant or malignant, you have to go for surgery. So this requires surgery. And then of course, surgery will be determined whether it's a papillary or whether it's a follicular, whether it's a medullary carcinoma. So this is an entirely different scenario. The main message is for a pediatrician, if you have a thyroid nodule, 1 in 10 will have a risk of malignancy. So that's why you have to be very, very cautious in that regards. So at the end, again, I'd like to thank Dr. Vibha, Dr. Sonal, Dr. Seema, Dr. Jyoti, and Dr. Manisha for having joined us for this wonderful discussion. We've already covered 2 very important parts which are commonly seen in pediatric practice, the growth and thyroid. We will now move forward the other 2, which are, one is very, very important in common is puberty, and the other one which is very intriguing, which will be DSD. So we'll be starting on puberty. And for the puberty module, we've got a lot of interesting cases which we'll cover. And for that, we are joined by an eminent panel of experts. We have got Dr. Vishnu, who is Associate Professor at Jaipur, Dr. Yuthika, who is the Director Regency IVF and Specialist in Pediatric and Adolescent Gynecology, Dr. Alka Jha from Fortis Delhi, and Dr. Sangeeta Das from AIIMS Nagpur. Dr. Sayan will be joining me with regards to discussion of the cases. And so just to introduce, Dr. Yuthika is currently working as a director of Regency IVF. She did her training from AIIMS and subsequently from the Royal Women's Hospital in Melbourne IVF and RCH in Melbourne. And she's been working a lot in regards to pediatric and adolescent endocrinology and gynecology. Dr. Vishnu, as discussed, has been associated with us for a long time, and he's working as a faculty and increasing pediatric endocrinology awareness around Rajasthan area. Dr. Alka is a senior consultant in Fortis Hospital, Vasant Kunj, and she is working mainly in terms of endocrinology and also a trainer in the diabetes course run by a very prestigious course run by Fortis CDoc and the British Medical Journal. And Dr. Sangeeta, who is part of our team and who is undergoing our training with regards to the fellowship program, is currently working in Department of Pediatrics at AIIMS Nagpur, and she is very keen in terms of pediatric endocrinology. So we'll be touching base about various aspects of pubertal disorders, and we know that pubertal disorders are very, very significant. They are very common, particularly precocious puberty is very common in girls. Most of it is physiological. It is less common in boys, but it is more likely to be pathological. So if you have a boy with precocious puberty, you have to be more worried. If you have a girl with delayed puberty, this is what I'll talk later on, you have to be more worried. But still you have physiology and pathology for which you need evaluation. So how do we define precocious puberty in girls? Anybody who has pubarchy or thylarchy before 8 years of age or vaginal bleeding before 9.5 years of age is considered to be early or precocious puberty in that regards. There is a very interesting association between clinical evaluation. And again, we'll focus on clinical evaluation. If you do your clinical evaluation well, you will make the right diagnosis. If you have a child who has no breast development and pubic hair development, this is precocious adrenarche. If you have a child in which you have got no breast development and no pubic hair development, but you have vaginal bleeding, you have to think of a local cause. This is not an endocrine cause. Look at a foreign body, a tumor, a trauma, or abuse. If there is breast development only and there is no pubic hair development, this is very interesting. This could be hypothyroidism. And finally, if you have complete development, synchronous development, breast, pubic hair, and bleeding, it is central precocious puberty is what it will go from that perspective. So how do you approach? If you have isolated pubarchy, look at DHEAS, which is the best marker for adrenal androgens. If DHEAS is low, this is just pubarchy. If it's 40 to 135, this is adrenarche. So adrenals are producing. If it's very high, this is exaggerated adrenarche. More than 135 in a young child, think of a tumor, think of CH. You have to do 17-hydroxyprogesterone and imaging. If your 17-OHP is low, then it's more likely to be an adrenal tumor. If it's borderline, do a ACTH test. If it's high, this is of course proven 21-hydroxylase deficiency. If there is only vaginal bleeding, this is a local cause. If it's a complete development, look at bone age. Bone age is retarded, think of hypothyroidism. Bone age is normal, this is slowly progressive puberty. If it's advanced, look at LH. LH is prepubertal, it is peripheral, very rare. Otherwise, it's usually central. If you have a girl who is below 6 years, get an MRI done. Above 6 years, no need for MRI. So essentially, DHEAS will give you an important picture if there is only pubarchy, and bone age and LH will give you a picture if you have a complete development. If you remember this, most of our cases will become very easy to go forward. And I'll invite Dr. Sayan to focus on these cases.
Thank you, sir, for the introduction of to precocious puberty. So we have a 7-year-old girl who presented to us with thylarchy, complaints of breast development. Now, on visual inspection, she had a breast stage 2, no pubic hair development, no menarche, height was doing fine, bone age as per her chronological age, LH, FSH, LH was undetectable, so was estradiol. So, Dr. Vishnu, is this precocious puberty?
7-year-old girl presented with the thylarchy breast stage 2 with no pubic hair. What is important in this case is that bone age is not advanced, which is 6.5 years in comparison to chronological age of 7 years. LH and FSH are also prepubertal, as well as estradiol level is also low. So whenever a girl presents to us with the complaint of breast development, we have to first confirm the presence, whether we are actually dealing with true breast development or it is lipomastia. In that case, we have to confirm the presence of breast development by putting our thumb and index finger around the areola and feeling for the resistance while approximating that, which is not felt in this case. So it is a case of lipomastia rather than true precocious puberty. which is a very common scenario in obese girls as well as boys. This diagnosis can also be confirmed by the presence of vaginal mucosa, which is red, suggestive of low estrogen exposure. So this is a confirmed case of lipomastia rather than true precocious puberty.
So what are the key
We have to
messages?
reassure the patient in this case, and nothing specific treatment is required. So key message is that we have to confirm puberty before doing extensive workup. Lipomastia is very common, especially in obese patients.
Thank you, sir, for this wonderful message. Is that not only visual inspection, but we have to confirm by palpation the early onset of breast development. So moving forward to the next case, we have a 2-year-old girl presenting to us with complaints of thyroid. The onset was 6 months back. It is slowly progressive, but on presentation had a breast stage 3, no pubic hair development, no onset of menarche. So Dr. Alka, how do we approach this case and how do we move forward?
Okay, good evening, everyone. So here we have a 2-year female who presented with thyroid, which developed actually at the age of 1.5 years. And over a period of 6 months, it progresses only to the stage B3, and there was no pubic hair, no menstrual flow. So this suggests that it is a slowly progressive isolated thyroid. But at the same time, we should keep in mind that it could be an initial manifestation of progressive puberty. However, it looks less likely because as the name suggests, the progressive puberty means rapid progression. So by the age of 2 years, this girl should have reached the menstrual cycle, which is not there, and that we commonly see in our patient of hematoma or the McCune-Albright syndrome. If we look at the height of this patient, which is height is 88 centimeter, which is quite adequate for this age, and there was no cafe spot, which is a cutaneous marker for McCune-Albright syndrome. So this seems that it is a isolated thyroid which is slowly progressive. Now, moving forward, we have now established the extent of the precocious puberty. Now let's follow the algorithm further down. To confirm this, my clinical diagnosis, I would like to go for the 2 things. The one is the bone age and second is the gonadotropin levels. So if the bone age, let's say, is retarded, which suggests that it could be, there is a possibility it could be because of the long-standing uncontrolled hypothyroidism. If the bone age is normal or the growth is normal.
Appropriate for the age.
Yeah, appropriate for age, yeah. If the bone age is appropriate for this age and the growth is normal, like for this our patient, so it suggests further it is a slowly progressive isolated thyroid, which can be further supported if we do the gonadotropin levels, which will show a prepubertal level with the detectable FSH, low E2. On the extreme hand, if we found that there is the bone age is advanced and the growth is advanced in terms of increase in height age, or the LH levels are more than 0.3, increased level of estrogen, increased endometrial thickness on ultrasound, that suggests it is a progressive puberty. So this is a simple case of a slowly progressive isolated thyroid, which usually does not require any treatment. It spontaneously regress on its own over a period of 4 to 5 years. But at the same time, we should keep a close watch for the progression of puberty. That is very important message through this case.
Yes, thank you. So what
are
the
key? I'll add here the key message is that it is this isolated thyroid is very common scenario, and we do see in our clinical practice at times, many times create confusion in both physician as well as create anxiety in parents. But by simple breast examination and by doing simple baseline test, we can differentiate this isolated thyroid from the progressive puberty, and we can alleviate the anxiety in the parents also and unnecessary investigations.
Yeah, thank you for this important message. Is that even when we diagnose a case of slowly progressive puberty, follow-up is very, very essential, and we shouldn't label this as a slowly progressive form before 6 months. Now, moving forward to the next case, we have a 6-year-old girl who again presents to us with thyroid. Thyroid started 1 month back, height of 124. So height is advanced in this case. Pubic hair has also developed. Breast development is B3 and mucosa is pink. This is the plot of his growth chart, and the bone age is also plotted here, which is showing that bones are completely very much advanced for the age. So Dr. Sangeeta, do you think this case is different from the previous 2?
Yes, this case is completely different because if we see that this age of onset is 6 years, and this child has come with thyroid, and there is also puberty, and the pubic hair is stage 2. And there, so if we see the definition of precocious puberty, so if any thalarchy is there more than 8 years of age, so that means this case will fall under the category of precocious puberty. Now this is a complete puberty because there is thalarchy, there is puberty also. Mucosa is also pink, that means there is estrogen exposure. But to evaluate further, we have to know the bone age and also the gonadotropin levels. Now we can already the height, so the height is almost, it is more than 90th centile and the bone age is advanced. So that means this is a precocious puberty. Now we have to differentiate whether this is a central precocious puberty or peripheral. What is the level? For this, we have to see the gonadotropin levels. So LH level, if it is less than 0.1, so it will be a case of peripheral precocious puberty, and if it is more than 0.3, so it will be a case of central precocious puberty.
The gonadotropins were very much raised.
So that is a case of central precocious puberty. So that means this case is going to be benefited with GnRH analog treatment. So our key message here will be, whenever there is a child presenting with a case of complete precocious puberty, we always have to see the bone age so that this patient will be benefited by GnRH treatment or not.
I think the other big message is that if you have a child who has the onset before 6 years of age, that is a very clear indication for GnRH analog. Yes. Between 6 to 8 years, you have to look at 3 things. What is the bone age? What is the uterus? And how is the progression? So Sayan has been looking in terms of slowly progressive versus rapidly progressive. What do you think are the key clinical clues that you will suggest that this is rapidly progressive puberty?
Clinical clues to suggest rapidly progressive forms are the breast staging, and the obvious form will be any discharge and all which are occurring. But the most important point which Dr. Sangeeta has mentioned is the bone age. And our app very well mentions it. If the height SDS is more than 1.5, chances are that it will be rapidly progressing. If the height SDS is less than 1.5, find out the height SDS for the bone age. And if it is less than -2, you are more likely that you are dealing with rapidly progressive forms.
So again, growth and bone age will tell you a picture. If you are in doubt, ultrasound, and ultrasound will also tell you whether you are going to be progressive or not. Look at endometrial thickness. Look at the overall size of uterus, the shape of uterus, which becomes more like rather than a tubular structure, more like a corporal structure. These will tell you a picture.
Thank you, Dr. Sangeeta. Moving forward to the next case. Now, this is a 7-year-old girl presenting to us with complaints of only vaginal bleeding. This was a single episode. On presentation, we didn't find any breast development or any pubic hair development, just complaints of vaginal bleed. And on systemic examination, her vaginal mucosa was red, so no signs of systemic estrogenization. So, ma'am, I can't match all these findings. Could you kindly help me through this? Dr. Yuthika, ma'am?
Thank you, Dr. Sayan. So in this young girl of 7 years, without any features of puberty, there is isolated vaginal bleeding. So this is a non-endocrine cause of vaginal bleeding, most likely a local cause. And examination of the local examination of vulva is showing there is no estrogenization either, which is why the mucosa is red. And that is why, you need to rule out local causes in this case. You should consult a gynecologist. There could be a very, very mild case of vulvovaginitis, which causes a lot of itching. And that's why, sometimes the child scratches and there is a mild bleeding or spotting in a similar episode like that. Or it could be a sinister thing like a foreign body in the vagina, or there could be a more severe infection or even a tumor. So vaginal rhabdomyosarcomas present with isolated vaginal bleedings, and many other sinister cases like even of sexual abuse could be that. So it needs to be properly evaluated, especially if you have no features of estrogenization, otherwise no breast, and no features of, sometimes it could be a rapidly progressive puberty, peripheral puberty, where you don't have breasts too big and you start have periods. But in those cases, the vaginal mucosa is a bit pink, estrogenization. So you should look for estrogenization. In this case, I would, you could do hormones to confirm that there is no early signs of any hormones coming. But the major feature would be doing, refer to a gynecologist and getting the local evaluation done.
And we did the hormonal study. It showed a prepubertal hormonal levels. And thereafter, on referral to a gynecologist who did a vaginoscopy, a foreign body was found.
Yes. So even for younger children, it's very difficult to, examine them locally. So you could do endoscopic examination under anesthesia, which is called vaginoscopy, which is done in a way in which the hymen skin is not damaged and, the local examination is done. And if there is a foreign body, it can be taken out at the same time.
Thank you for ma'am for this very important message. And what are the key messages that you'd like to give us from this case, ma'am?
So it's very important to look at signs of puberty in a case of vaginal bleeding. So not all vaginal bleedings are periods. And if there is no onset of puberty, no features of estrogenization otherwise in the body, local cause should always be ruled out.
Thank you, ma'am. Thank you, ma'am. Moving forward to the next case. This is a 7-year-old girl presenting to us with complaints of thyroid. Now, the thyroid started 3 months back. But on anthropometry, we found that she was very short. A 7-year-old girl having a height of only 100 centimeters. Now, she first went to a gynecologist and an ultrasound was done to check for other signs of systemic estrogenization like ET thickness or corporal index, as just mentioned. Incidentally, a huge cyst was found. This is her growth chart, the plot on her growth chart. And on Tanner staging, we found that the breast stage was 3. There was no pubic hair development. Mucosa was pink. So signs of estrogenization in a short child. So Dr. Vishnu, could you kindly take us forward from this?
This 7-year-old girl presented with the breast stage 3 of 3 months duration with pink vaginal mucosa, which is suggestive of recent estrogen exposure. What is important in this case is that she is significantly short for her age, and large ovarian cyst is also visible in the ultrasound of right ovary. Every child with precocious puberty should be tall for age, but in contradiction to that, this girl is significantly short for his chronological age, suggestive of hypothyroidism, which can be confirmed by the assessment of the bone age as well as evaluation of the TSH level, which is
so the bone age was delayed, sir. Bone age was 4 years.
4 years, and what is the TSH level?
So the thyroid status was done, it was more than 100, sir.
So this is a confirmed case of hypothyroidism. The key message in this case is that every patient with precocious puberty should be tall, but if it is associated with growth failure, it is suggestive of hypothyroidism.
Yes, sir. The parents of the child are also concerned about the ovarian cyst. They want it operated, sir.
There is no need of operation. By supplementation of thyroxine hormone, it will gradually suppress and resolute. So there is no need of acute surgical management in this case.
Yeah, thank you, sir, for this wonderful message that precocious puberty with short stature, always rule out hypothyroidism and no need to treat an ovarian cyst because it will self-limit on treatment. Moving forward to the next case, we have a 1.5-year-old girl presenting to us with menarche. Now, she has breast development, no pubic hair development. Height was on the higher side. So, Dr. Alka, is this case different and how can we move forward to assess this case? Dr. Alka?
So while Dr. Alka is joining us, this is clearly a case which is very early onset. And what we
Sir, I can, excuse me, sir, I can put a light on this case.
Yeah. Dr. Sangeeta.
Yes, sir. Yes, sir. So this is, as we can see, by definition, this is a case of precocious puberty. And this is an early onset because the age is 1.5 year. And if we see that the child attained menarche at breast stage 2, so that means this is a rapidly progressing precocious puberty. So usually in these cases, the bone age is going to be advanced only, but we have to differentiate based on the gonadotropin levels.
Yes, the bone age was advanced in this case. And we went in for the gonadotropin levels, as you just mentioned, and these are the reports which are mentioned.
So clearly LH and FSH, they are on higher, they are on higher levels. And so this is a case of central precocious puberty, which is early onset and rapidly progressive. Now, there is a key message: any of precocious puberty is right, there is high likelihood of organic pathology. So
yeah. So any other investigations you wanted to do in this case?
So we want to do the this MRI brain for this child. So
yeah.
Is it?
So yeah, we did the MRI and this is what it showed.
So there is a the finding is hypothalamic hematoma, which is there and which can be easily found in such cases where there is early onset rapidly progressing central precocious puberty, which is a benign in nature, and it gets benefited with GnRH analog treatment. Usually surgery is not required in such cases.
I think this is a big message. Anybody who is less than 6 years of age, you have to think of an organic pathology. And beyond 6 years, the yield is less than 1%, so you don't really need to do a MRI. And if you have hematoma, don't refer to the neurosurgeon because unnecessarily surgical intervention will be done. So the key message, of course, are that high LH, early onset, it's organic, and MRI below 6 years of age.
Moving forward to the next case, we now have a 1-year-old girl presenting with thyroid. This is of 3 months duration. Height is 88 centimeters. So height is on the higher side. Her breast staging is B3. There is no pubic hair development. Mucosa is red here. So advanced breast staging, but no other signs of systemic estrogenization. Now, this is what was found on blood investigations, is that the LH, FSH, and estrogen were undetectable. So, ma'am, is this the effect of mini puberty? Yuthika, ma'am?
Thank you, Dr. Sayan. So again, a very, very young girl presenting with Thyroid and an advanced breast development with no current features of estrogenization because something transient happened, which sort of basically increased the breast size, and now the mucosa is red. And definitely the LH and FSH levels and even the estrogen levels are less. In this particular case, definitely there is feature of peripheral, there is pubertal signs, but again, because the hormone levels are showing, are normal, you could think of something like an exogenous cause or a transient cause of estrogen production, maybe a small cyst which produced. So whether there was any local cause, so yes, of course, yes. There were labial adhesions which were treated. So you can get that kind of presentation if somebody is being treated with topical estrogens for management of labial adhesions, because estrogen definitely gets absorbed topically and can have systemic, side effects leading to breast development. In fact, that is the kind of presentation that you would see in a 1-year-old girl, because that is a time when the labial adhesions, when the estrogenization of the maternal estrogen goes away, the labial adhesions most commonly present. And in fact, they are not nowadays, we don't recommend to treat asymptomatic labial adhesions because they resolve on their own as the child grows, and definitely treating them with topical estrogen can have these kinds of side effects. So the key message here is that when there is low peripheral LH and there is low estrogen, always think of exogenous cause, any additional cause or maybe a transient cause of estrogen that can lead to precocious puberty. And in this particular case, it was topical estrogen, which is now not recommended to be treated for labial adhesions.
Yeah, thank you, ma'am, for this message. And this is why you always tell us not to treat labial adhesions with systemic estrogen at the first go, exactly for this effect. And this is what is also mentioned in the chapter you have written for us. And moving forward to the next case.
So just about, we talk about precocious puberty in girls. Now we just have to go through about boys. What we need to understand is that organic pathology is around 40% more likely in boys. Now the problems can happen either at the level of the hypothalamus or pituitary, which is central precocious puberty, or at a peripheral production via the testis or the adrenal, which is a peripheral precocious puberty. The most important parameter to look at is, of course, LH. If your LH is more than 0.2, this is central, in which you will have an increased testicular size. The most important thing to look at in a girl with precocious puberty, we discussed, is pubic hair, because that gives you a lot of information. The most important thing to look at in a boy with precocious puberty is the testicular size. So if you have a pubertal testis, this is more likely to be a central cause. While if you have a peripheral cause, you will have a small testis, if you particularly have an adrenal clause like CAH in that perspective. So we need to understand about pubertal progression. The most important thing, of course, is the testicular enlargement, and a testicular volume above 4 ml suggests that you have entered into puberty. Now, what you need to remember is that 70 to 80% of testicular volume is actually the Sertoli cells and germ cells, and only 20% of it is Leydig cell. So if you have a HCG producing tumor or testotoxicosis in which the LH is working more, you will have a testis in which Leydig cells are more, so it will be in between. The testicular volume will give you a clear picture. Small testis 1 ml, 2 ml, that is CAH with peripheral precocious puberty. More than 8 ml, 10 ml, you definitely more than 4 ml, you start thinking of actually a true central precocity. In between is more likely to be a HCG producing tumor or a testotoxicosis. And that's why this examination becomes very, very important. And you should use a orchidometer to assess. This is what I'm talking about. Large testis, precocious puberty central, small testis peripheral. In between the two is HCG dependent. And of course, if you have a rare scenario of one big testis, this is a testicular tumor which is causing precocious puberty. So anybody who has got a pubarchy or increase in testicular volume before 9 years of age, we consider it to be precocious puberty. We'll now move forward to the few cases in this scenario.
So this was a 4-year-old boy presenting to us with signs, with the complaints of early development of secondary sexual features. So Dr. Alka, this is the boy when he presented to us. So kindly take us forward from here, Dr. Alka. Dr. Alka, are you here?
Yeah, thank you. Thank you, Sain. So here we have a case who is presented with the enlarged testicular volume and the phallic size in a very young boy, 4 years of age. So this is clearly a case of precocious puberty. And here I'll consider this as a central precocious puberty, because as Dr. Anurag just mentioned, that whenever we are evaluating a boy with a precocious puberty, always look at the testicular volume. Though the testicular volume is not mentioned here, but we can see that this is very much higher side for this age of 4 years. So both the testicular volume is increased. So we'll consider this as a central precocious puberty. And further, we would like to go for the gonadotropin levels to confirm further diagnosis.
Yeah, so on the gonadotropin levels, LH was 2.2 and the testo was 80.
Yeah, so here we can clearly see that the gonadotropin levels are very high. LH is way away the normal levels with the high values of FSH as well as the testosterone. So this confirms the central precocious puberty. To delineate the cause, we would like to go for the MRI brain for this patient.
Yeah, so we did an MRI and this is what we see.
Yeah. So the MRI of this small boy showed a hypothalamic hematoma. So this patient required, this is causing the precocious puberty, central cause precocious puberty, and this patient required further GnRH analog for the further management.
Yeah, would you like to refer him to a neurologist for the hematoma, ma'am?
So usually in majority of the patients with hypothalamic hematoma do not require any neurosurgical interventions. They respond very well with the GnRH analog. But in case if the hematoma is very huge in size, like more than 8 centimeters, if the patient is having a refractory seizures, yes, we can take the opinion. But in majority of the cases, we do not require any surgical interventions.
Thank you. And what are the key messages that you would like to deliver?
So definitely in all the boys who are having a precocious puberty, always look for the pathology because they are more common in boys.
Yeah. And the testicular volume is also very important, as you very nicely mentioned, for distinction.
Definitely. Testicular volume is very important. In central cases, the testicular volume is usually more than 10 ml in patients, in boys. And all patients, all boys with the precocious puberty should go for the MRI head.
Yeah. Thank you so much. Moving forward to the next case. This is a 7-year-old boy presenting to us with, again, complaints of early development of secondary sexual features. Now, Dr. Sangeeta, this is the patient when he arrived to us. Is this again central precocious puberty?
So as we can see, the penile length is not commensurating with the testicular volume. As per the age of the boy, the penile length is more and the testes are small. So as sir has discussed, if the testicular volume is small, in a case of precocious puberty, it is likely to be peripheral in origin. Now, if we see clinically that this is peripheral, we have to see the source of androgen production, for which we have to do the gonadotropin levels. So LH level we have to do. So
yeah,
as
LH
we can
was,
see,
LH was 0.1.
So LH is
very high.
Yes. So LH is less. So that means this is a case of peripheral precocious puberty. Now there can be two sources of peripheral precocious puberty. One is adrenal, one is testis. So for seeing that, we have to since the adrenal causes are more common, we have to go for adrenal imaging and 17 OHP levels. So usually adrenal CT is preferred.
Yeah, this was the adrenal imaging and it is shown here.
Yes, we can see that there is hyperplasia of one adrenal gland. So that means it is high. There is high chance that this can be a case of CAH. So there we have to go for 17 OHP levels.
Yeah, 17 OHP here was very high. It was 120 nanograms per ml.
Yes. So this suggests that this boy is having CAH, precocious puberty due to CAH. So they will be benefited by steroid replacement. So.
Yeah. So a wonderful message again to differentiate central from peripheral. Look at the testis size, as Sir and Dr. Alka and Dr. Sangeeta very well mentioned. So what are the key messages that you'd like to give us, Dr. Sangeeta?
So any cases of precocious puberty, always before going through the lab investigations, we always have to see the testicular volume. If it is small testicular volume, definitely we have to look up further causes for peripheral precocious puberty. And in such cases, 17 OHP levels are very vital to determine the etiology.
So Dr. Dhwani, in this scenario, this child comes to you after 3 months now, and now suddenly the testicular volume has gone up. So what do you think has happened? So he was CAH, you have treated with that. What do you think has happened? Why will his testicular volume go up now? So it has triggered central precocious puberty. If your bone age becomes advanced, then it will trigger the central precocious puberty. And because of no treatment, the androgens were suppressing it. And now as soon as the androgens have come down, suddenly the pituitary will wake up and it will cause that. So you will need to be wary. In that scenario, you have to add GnRH analogs. Now, just we have discussed a lot about precocious puberty. We'll now touch base about delayed puberty. Again, it's the opposite picture. It is much more likely to be pathological in girls as compared to boys. So a girl with delayed puberty, you have to worry more. But remember, 35% can still have CDGP. Often people say girls do not have CDGP. That is incorrect. Boys are more likely to have this in this perspective. So girls who have no breast development by 13 years or no menarche within 5 years of period, think of delayed puberty. The key workup is very importantly, like any short child, evaluate for all systemic illnesses. Look for liver, kidney, thyroid, celiac, all those things. Then if they are normal, look for gonadotrophins. High gonadotrophins will suggest that you have a gonadal problem. Do a karyotype, and then you can work up. Mostly it will be Turner syndrome. So most important differential is Turner syndrome. If it's low, you have to think of a central cause, and that becomes important. So now Dr. Sang will carry forward with the case.
Yeah, moving forward to the next case. This was a 13-year-old girl presenting to us with complaints of no development of secondary sexual features. On examination, breast and pubic hair were not developed. Height and weight were doing fine. LH FSH was undetectable. Now, the most astonishing feature was that on an ultrasound, she had an absent uterus. And this is why the child presented to us. So, Dr. Yuthika, how can we manage this case? Ultrasound showing no uterus. Ma'am?
Thank you, Dr. Sayan. Again, this is a 13-year-old girl. It's a very common presentation nowadays in gynae clinics for a 13-year-old girl to be presented with a concerned mother showing that she has not started her periods and she is basically delayed because of the earlier onset in the peers. But I would say, and especially in this kind of scenario where she has been investigated and the ultrasound is showing absent uterus, it would be probably devastating for the family. But again, whenever you have a case like this, very important to look at signs of puberty in other areas before going to the uterus. So if there is no breast, there is no estrogenization, the uterus will be very, very prepubertal and very difficult to locate. So many times, if the ultrasound is not done with a proper full bladder, and especially if the child is a bit obese, many doctors will actually miss a prepubertal uterus, which is a very paper thin structure. So if there is no breast, a small uterus would be missed, and such a devastating diagnosis can present. So never look for a uterus if there are no features of breast development and estrogenization in the other in the child. And in this particular case, when she's just 13 and is prepubertal clinically, her hormones are also showing prepubertal levels. She's probably not entered puberty, and I mean, I would definitely wait and ask for other features. Sometimes they develop vaginal discharge and all those kinds of symptoms, but not investigate straight away. Look for wait for a little while. So uterus can be very commonly missed. So the key message here is that don't go in for examination of uterus unless it is being done unless there is development of breasts. So because uterus can be missed, and a careful follow-up in this case would be needed to see whether this is a case of delayed puberty or not.
Thank you, ma'am. And these are actually cases that we see very commonly referred to us only because of absent uterus. And you have very well explained, ma'am. Thank you so much. Moving forward to the next case. This was a 16-year-old girl presenting to us with delayed puberty. There was no breast, no pubic hair development. Height was on the lower side, but weight was much more affected. LH and FSH again showed a prepubertal level, not appropriate for the age. And the referral physician advised estradiol. So Dr. Vishnu, do you agree? Patient presenting to us with hypogonadism advised estradiol.
What is important in this case is that this 16-year-old girl presented with no breast and no pubic hair development, as well as she is significantly short for age and also underweight. So we can predict the etiology of delayed puberty in girl by simple examination of the breast and pubic hair. No breast development with good pubic hair development is probably suggestive of GnRH deficiency, whereas no breast and no pubic hair is suggestive of CDGP or any significant systemic pathology, which is case in our case. Good breast development with no pubic hair development is suggestive of AIS, whereas both breast and good pubic hair development is suggestive of any local pathology. So whenever a girl presents to us the complaint of delayed puberty, we have to do certain screening investigation in form of CBC, ALT, LFT, RFT, free T4 TSS, serum prolactin level, as well as TTG.
So the hemoglobin levels were low in this case.
And followed by gonadotropin level. In this case, significant pallor is present, suggestive of significant systemic pathology. Along with anemia, clubbing is also present, probably clinching towards the diagnosis of celiac disease, which can be confirmed by the TTG level, which is high, which is significantly raised in this case. So,
yes, sir. The key messages that you want to give us in this case?
We should consider systemic causes in cases of low gonadotropin levels.
Yes, sir. And anemia
and associated features picture suggestive of systemic disease like anemia suggests celiac disease.
I think this is a very important message because like short stature, puberty is also. So growth, puberty and reproduction. These are three energy intense things. If the body is sick, it will stop them. So if you have not enough nutrition, growth, puberty, reproduction, all will be shut down. So especially in girls, less for boys because there the onset is there, you will not know about the progression. In girls, you will immediately know, period will stop. You will know that there is no ongoing estrogen exposure. So nutritional causes, systemic illness, very important to exclude in girls before you go ahead, especially when you have hypogonadotropic hypogonadism. Now, Dr. Vibha, how do you differentiate between a hypogonadotropic hypogonadism versus a functional cause of hypogonadism? What are the LH, FSH levels? How will they reflect in that?
So in the functional, LH, FSH should be like
which will be more affected, LH or FSH?
It is predominant, so the FSH should be higher than LH.
So if you have severe hypogonadotropic hypogonadism, both will be low. But if you have a functional anorexia nervosa, celiac, your FSH may be normal, but LH will be low because you are going into shell. You are becoming prepubertal in that scenario.
Thank you, sir. Moving forward to the next case. This was a 12-year-old girl presenting with main complaints of growth failure. Now, this is what we saw on the clinical examination. On anthropometry, she is very short. There's absolutely no secondary sexual features. She had additional findings of brachymetacarpia and webbing of neck. On further workup, we found that she had a very high FSH. And because she was very short, the referral physician advised her GH. So, Dr. Alka, what would be the GH dose you would advise in this case? Or would you like to do anything else?
Yeah, definitely. So from this scenario, it seems that this girl was actually diagnosed as a case of a Turner syndrome based on the clinical features like growth failure, poor SMR, with some, the features of sensitive of the Turners like brachymetacarpia or the webbing nerve with the background of high FSH. They started the GH therapy without getting the karyotypic, which is not actually advisable in this scenario. So all female patients who are presenting like this with the high values of FSH, they should go for the karyotyping, which is mandatory. And it should include the 50 metaphase plates so that we can look for the mosaic pattern also. Even if you are looking all the features, classical features of Turner in one patient, you should go for the karyotyping. That's a key message from this case.
What is the need for a karyotype, ma'am?
Yeah, because this is a very vital test. This will tell us the presence or the absence of the Y cell line. And we know that Y cell line is the risk factor for the gonadoblastomma. So if your patient, in such scenario, if you are doing a karyotyping and you are finding that patient is having a Y cell line, so we should go for a prophylactic gonectomy before doing and giving any GH therapy in such scenarios.
Ma'am, a very important point that you mentioned to us, because when this child actually presented to us, she had developed an abdominal lump. And as you rightly pointed out, she developed a gonadoblastoma, which could have been prevented early just by doing a karyotype.
So, Sayan, if you have done a karyotype and that doesn't show a Y line, when will you go for more studies for Y?
When she presents with virilization.
So if you have a girl who was normal and starts to virilize during puberty, again, that may indicate that there is somewhere Y line is there. So in that scenario also, you do a microdeletion study or you do for the fish for Y in that regard. Yeah. Okay.
So what are the key messages, Dr. Alka, would you like to give to us?
Yeah, the key message is that whenever we are dealing with such patients with the high FSH values, the karyotyping is mandatory, and always go with this slow pubertal induction so that we can give a patient for the better development of breast and the uterus, and the final height should not be compromised. Always go for the very slow induction over a period of 2 and 2.5 years.
Thank you so much. Moving forward to the next case. Now we have a 16-year-old girl with complaints of primary amenorrhea. Now breasts are pretty well developed, B4. But what is most concerning is that there is absolutely no pubic hair development. Height, pretty fine, weight going well, but signs of dysfunction of the gonads. FSH is very high with at 88. There are no features of hirsutism in this case. So Dr. Sangeeta, anything missing?
So if we see this girl, she's 16 years who has presented to us with primary amenorrhea. However, if we see the complete pubertal features, she has advanced thalarchy. Now, as sir has discussed before, if we see the pubic hair and relation, we do have certain clues for etiologies. Like if this girl is having thalarchy, but there is no absent menarche, so that means there is high chances that this child has androgen insensitivity syndrome. So usually this is a case of hypergonadotropic hypergonadism, as we can see from FSH level and LH levels. Usually karyotype is very, very much important in these cases. So if we can look from other aspect, any case of primary amenorrhea, if we recall the etiologies, there can be some structural anomalies. There can be, the cause can be AIS. The cause can also be other hyperandrogenism.
Now, Dr. Sangeeta, the karyotype, as you mentioned, will arrive pretty late. So any clinical pointers at presentation that will immediately give the diagnosis in this case?
So the thalarchy, the presence of thalarchy with absence of menarche and there is no pubic hair. So that will, this is a key message that it will point to androgen insensitivity syndrome.
And one more thing is that we most likely will find gonads which are palpable.
So palpable gonads, look for the gonads.
So although there will be AMH will be present, so there may not be the Mullerian system, but there will be gonads. And depending on the extent of androgen insensitivity, so they can be complete or partial or very mild. So in such cases, since she has already been raised as a girl, there is high chance that this is a complete AIS with the normal female genitalia.
So if you have good breast development, no pubic hair development, look for inguinal gonads. And before looking at gonad, you will see that she will be tall. So if you have anybody, you will usually have a short stature. When you say Turner syndrome, hypergonadotropic hypogonadism, this will be a tall girl because it's actually a XY where you have got an extra dose of shocks which is working. So this is classically tall girl. So any tall girl with primary amenorrhea is a very, very dangerous sign. Causes of tall stature with amenorrhea?
So tall stature with amenorrhea, XY gonadal.
So XY gonadogenesis, complete AIS, homocystinuria. That is something which will cause both of them. So you have to be cautious. So tall girl, short girl, we all know Turner syndrome, MPHD, hypothyroidism. Tall stature, you have to start worrying about other things also in that perspective. So tall stature, breast development, new pubarchy, AIS, most likely. Yeah. Okay.
Yeah. Moving forward to the next case. Now we have a 14-year-old girl presenting to us with complaints of hirsutism. She had menarche only 1 year back. Periods were occurring every 2 months. FGS was 6. USG showed ultrasonography showed a PCO appearance. And this is what the ultrasound showed us. And we have a diagnosis of PCOD in this case, which was made, and the child was referred to us. So, Dr. Yuthika, should we start treatment of PCOD in this case?
Now, this is a young girl with recent menarche and irregular periods. To call an adolescent polycystic ovarian syndrome, one thing is very important that, the symptoms either need to be persistent or symptoms need to be really severe. So in her case, hyperandrogenism is very mild. She has an FGS of only 6. And she has had a year of irregular period, which is quite common in that age group. When your period have just started, your cycles are still anovulatory. So right now, I think, and it's very, very common also in this age group, especially when you're doing a trans-abdominal scan, to, misdiagnose a multicystic ovary as a polycystic ovary. So I will not recommend even doing an investigation in the first 2 years of menarche for mild symptoms of hyperandrogenism, just like this girl, and, do a careful observation of this girl to see how her periods behave in the next 1 year. And if they tend to be persistent, then doing the workup is a better chance. Otherwise, you will have abnormal hormones in this because of the hyperandrogenism of puberty. So did you follow up this girl?
So I think, yeah, so basically this is the big message which is there, that you need to have an unexplained ovarian persistent, and on follow-up, this child became normal. So, so this is most likely a physiological cause. So Dr. Yuthika, why do you think there's a pandemic of PCOS which is there, that we are seeing so many? PCOS?
One, definitely the PCOS has definitely increased with the change in lifestyle and increased obesity. In the older age group, we are definitely finding increase in PCOS presentation. In adolescent girls, because of better ultrasound, more accessibilities, we are actually over-diagnosing certain physiological cases as well. And that's why the North American Society of Pediatric and Adolescent Gynecology, NASPAC, recommends to not investigate girls in the first 2 years of menarche. Because they in any ways have mild hirsutism, mild acne, because of the hyperandrogenism of puberty, and because of having irregular, anovulatory cycles in the first few years, they probably have the irregular periods. So very important to not label them as PCOS and reassess them after gynecological maturity, which is generally said, after 2 years, if the problem is persisting, you can still label them as at risk of PCOS and do the lifestyle thing, because they can still grow out of it if their periods, if their lifestyle is better, their weight loss happens. And only after 5 years post-menarche, if they still continue to have irregular periods and the polycystic ovarian morphology, that is when we call it PCOS. So key message in this girl is we have to avoid investigating for minor causes of hyperandrogenism. So clinically, if it is very severe hyperandrogenism or moderately severe anovulatory periods, then only investigate and not label them, still call them at-risk PCOS, do lifestyle changes, and they might grow out of it.
So as we've been discussing, the most important thing in a child, so if you have to look at the most important thing in a boy with precocious puberty, you look at the testicular volume. Most important thing in an obese child is height. The least important thing in a girl with hyperandrogenism is PCO appearance. It has no value in adolescents. 20% girls will have PCO appearance. So this is of no value. I think that's a big message.
25% of girls as it is have. So even adult women have a polycystic ovarian pattern, which just by having the morphology doesn't mean that they have the polycystic ovarian syndrome. Because these girls also have irregular periods, it's very common for gynecologists to label them as PCOS because adult women don't have irregular periods. So in this case, and this message is mainly for gynecologists because they are more, they see more of normal grown mature women who have regular periods. But for younger people, even these irregular periods are normal.
Okay. I think that's a very, very important message from there. Now, just towards the conclusion part, we'll talk a bit about delayed puberty in boy. Remember, 80% of boys will have CDGP. But if you have a tall child who has got a pubic hair development, who has a stalled puberty, this is not CDGP. So CDGP, the cardinal features are short stature, so they have a constitutional delay of growth, no pubic hair development, their bone age will be delayed, and they will all not have any CNS features. So, of course, in the initial phase, you have to do all these systemic features you have to exclude. Then if the testosterone is high, that is most likely Klinefelter syndrome. A tall individual with stalled puberty, with gynecomastia, that is hypergonadotropic hypogonadism, shorty testis, that's Klinefelter syndrome. If you have a low LH, however, and you have a testicular volume above 1 ml, and you have a short stature, no pubarchy, think of CDGP. In this scenario, inhibin B will give you a clue. Increased testicular volume and a high inhibin B is constitutional delay of puberty and growth. Testicular volume below 1 ml, anosmia, synkinesia, CNS features, think of a hypogonadotropic hypogonadism. So this looks reasonably complicated. The key message is that if you have hypogonadotropic hypogonadism with short stature, no pubarchy, high inhibin B, this is CDGP. If everything is low, you can think of HH. The best way is to give a course of testosterone and follow up in that perspective. And of course, anybody who is not enlarging by 14 years is what you consider. So pointers against CDGP are if you have pubarchy, you had development and you stopped, normal growth and neurological features. So this is the red flags. Red flags when there needs to be an evaluation referral to an endocrinologist in this scenario, and that becomes important in that regards that we already discussed. Yeah.
So the next case is of a 16-year-old boy presenting to us with delayed puberty. Onset was at 13 years, but for the last 2 years, it has stopped. Testicular volume on presentation was 3 ml, was soft, had development of pubic hair. Height was pretty good at 170 centimeters, was diagnosed as a case of CDGP and referred to us. So Dr. Alka, is this CDGP?
So here we have actually a boy who actually presented with the normal onset of puberty and growth, but suddenly his pubertal progression had stalled, arrested. Stalled means he was okay before, but now it is stopped because of any reason, some insult, either genetic or it could be some acquired causes. So the diagnosis of CDGP is inappropriate in this scenario. CDGP means there is a global delay in the growth, in the bone age, and there is no puberty. The reason being there is a delay in the triggering of GnRH. But once they are triggered, their progression of the puberty and the growth is normal. So in this patient, there is a stalled puberty. The boy has attained a good height, has developed the puberty. So this is not CDGP. This is a stalled puberty and need further evaluation for the cause.
And the child had neurological features.
So we need a MRI for this patient to look for the pathology. So the key message is that, as sir said, that 80% of these boys, they will be CDGP. But if the boy is attained good height and there is a puberty and their bone age is normal, then we need to look for the pathology, sir, in these patients.
Thank you for this wonderful message, Dr. Alka. Moving forward to the next case, this was a 17-year-old boy presenting to us with again complaints of pubertal concern. Again, onset was at 12 years, but now stopped for the last 3 years. In this case, testes were of 2 ml volume, but it was firm. Additional findings of gynecomastia were also found in this case. So, Dr. Vishnu, is this case CDGP?
No, I am not convinced with the diagnosis of CDGP in this case. What is clinching in this case is that this boy initially had normal development but from last 3 years there is no pubertal progression, which is suggestive of stalled puberty, which is strongly against the diagnosis of CDGP. Along with this, there is small firm salty testes along with gynecomastia, which is suggestive of significant acquired sinister pathology. Whenever a boy, next slide please.
Yeah, the height was also on the higher side. It was 182.
And this child is also tall for his age. Whenever a boy presents to us with delayed puberty, we have to do screening investigation followed by gonadotropin level. What we can see that gonadotropin level, both LH and FSH level were high, along with low testosterone, which is suggestive of chromosomal anomaly, which can be confirmed by
Yeah, so we did a karyotype and this is what we found.
And so this confirm the diagnosis of Klinefelter syndrome.
Yeah. So the key messages that you would like to give to us?
That whenever a child presents to us with high FSH, it is suggestive of acquired gonadotropin failure and suggestive of chromosomal anomaly.
So just to highlight 3 types of scenarios, you have a short child with no pubic hair development, delayed puberty, that is CDGP. A tall child with gynecomastia with normal puberty and shorty, firm testis, Klinefelter syndrome. Very soft testis, some pubic hair development, normal stature, soft testis, that is more likely a Kalaman syndrome. Ask for anosmia in that scenario. So just by looking clinically, you can make a diagnosis. We have developed a puberty interpreter, which Dr. Sayan has presented a paper across in various organizations, which just allows you to fill certain scenarios, and based upon that, it gives you a diagnosis about various forms of puberty, whether it is central, peripheral, delayed, normal, and again with a high level of concordance. So we have been trying to develop application-based point of care guidance, which help you assess and evaluate appropriately. So I think we will stop at this point of time with regards to the pubertal disorders. I'd like to thank Dr. Sayan for being here, for discussing all the interesting cases, Dr. Vishnu, Dr. Alka, Dr. Sangeeta, and Dr. Yutika for being part of this wonderful discussion. We'll see if there are any particular questions related to that, and we'll go forward from there. So there is a question from Dr. Fahmida. In a 16-year-old girl with Turner syndrome who was on regular monthly 21-day estrogen and 14-day progesterone with initial cyclical period, if no cycle for 3 months, how would we adjust the hormonal replacement? I think the scenario here may be two. One is whether we need to increase the dose of estrogen and whether there is an adherence issue. So whether the patient is actually taking the medication. So I like to get an ultrasound done to see for the endometrial thickness. If the endometrial thickness is less, we have to think of adherence as an important parameter as well. So Dr. Gayatri is asking about case 9 with delayed puberty. Explain once more. So which one was case 9? Now this is, we'll just go through that. So delayed puberty, we basically discussed that the most important aspect is to look at the clinical parameters, and case 9 for delayed puberty was basically a girl who was 13-year-old who was labeled as an absent uterus. The message there was that if you do not have any breast, you will not have any uterus on ultrasound often, because uterus is very small in breast 1, breast 2. So there is a message that do not do an ultrasound unnecessary in that regards, Dr. Gayatri. Dr. Linda is asking, in girl on GnRH analog, how do you monitor progress and what do you look for? The most important parameters to look at are clinical parameters. I was part on the guidelines for the GnRH analog committee, and what we found was that biochemical parameters are not that important. If your bone age is being suppressed adequately, if the height velocity is normal, that is the key parameter. But if the bone age is progressing rapidly, or you have a height which is progressing rapidly, you look at the 2-hour LH level after the injection. If the levels are above 5, then you start worrying. If it's below 2, it's considered to be fine from that perspective. So these were the key aspects which were there. I like to thank again Dr. Sayan, Dr. Vishnu, Dr. Alka, Dr. Sangeeta, and Dr. Yuthika for being part of this panel. And we will now move forward towards the last session, which is quite interesting and intriguing, because what we're going to discuss now is about DSD. And often there is a lot of confusion which is there on DSD. We hope that over the next 45 minutes or so, we will be able to cover these confusions and to help us out understand this in a further manner. We have joined by a team of experts again from across the country. And it's a pleasure to invite with us Dr. Purnima, who is working as a pediatric endocrinologist at St. John's Hospital, Bangalore. Dr. Varuna Vyas, who is working as a consultant at AIIMS Jodhpur. Dr. Shalmi Mehta, a well-known pediatric endocrinologist from Gujarat, Ahmedabad. And Dr. Sajali, who was again one of our fellows and who is currently working in Pune and probably going to the UK for further training in that regard. I'll be joined by Dr. Vibha as well for the discussion in case scenarios. So Dr. Purnima, as we discussed, is an assistant professor from St. John's Medical College, and she is actively working on type 1 diabetes and closely involved with our group. Dr. Varuna Vyas is an associate professor in pediatrics, and she runs a training program also in AIIMS Jodhpur on pediatric endocrinology. She did her undergraduation and post-graduation from Lady Harding and Maulana Azad, and senior residency from All India Institute, and has done training under Dr. Ram Menon as well with regards to pediatric endocrinology, very active in pediatric endocrinology area. Dr. Shalmi, very senior pediatric endocrinologist trained in Canada, and she's working in Ahmedabad. And Dr. Sajali, who is in Pune, and she was with us. And a couple of years ago, she has returned back to Pune in that regards. So just before we start further discussion, we'll have a quick 10-minute overview of DSD, and then we'll start on to cases. So we all know that right from the initial stage, there is no gender discrimination. It's all gender non-dimorphic to begin with. There are multiple stages which include the genetics, the gonadal development. With gonadal development, we have development of the adrenals and the kidneys. So if there are gonadal developmental problems, particularly like NR5A1 or WT1, you will have a risk of a renal or an adrenal abnormality which may happen. From there, you have production of the hormones which then act on their receptor to cause a normal development. Any abnormality that you have, in particular in the XY individual, are usually acts of omission. So if there is no gonad formed, if there is no testis formed, if there is no testosterone formed, or if the testosterone is not acting, you will have a XX DSD. In this scenario, you may also have renal and adrenal defects, as I discussed earlier, and you have to be cautious about that. Now, testis has got two compartments. Sertoli cells produce AMH, which cause regression of the Mullerian structure. So if you have scenarios where both the compartments are affected, you will have gonads as well as Mullerian structure. But if you have isolated testosterone problem or androgen insensitivity, uterus will not be there. So Mullerian structure absent, testis present, basically will suggest a steroidogenic defect or an effect of testosterone action in that regards. Now, in females, if you have a problem which is also there in form of increased production of androgens, that could be an adrenal cause in the form of CAH, which becomes important in that regards. Now, most of these scenarios, if you have a steroidogenic defect or a biosynthetic defect or action defect, uterus will be absent, which is what we have discussed. Now, XX-DSD is an act of commission. If you have a girl who has got no bipotential gonad, no ovary, no estrogen, no aromatase, no estrogen receptor, will have a normal female development. So the default mode is a female development. But if you will have a XX-DSD, there has to be more androgens which are coming from. And they may come either from the adrenal or from the ovaries in that perspective. This is the basic difference between XX and XY DSD. And of course, you will not have any gonads. So throughout our presentation, we'll talk about a 2x2 table, gonad plus minus, Mullerian structure plus minus, and that will give you a diagnosis in most cases in that perspective. So DSD, XX-DSD as discussed, will have Mullerian structures and no gonads, usually androgen excess, mainly 21-hydroxylase deficiency. 95% of all XX-DSD will be CAH, 21-hydroxylase. Rare forms will be aromatase deficiency. How will you identify aromatase deficiency? You will have maternal virilization, which is also there. And very importantly, the child will not virilize after birth. In CAH, the penile size or the phallic size will continue to grow, while in aromatase deficiency, the size will not increase because there is no androgen production, no estrogen production, basically. Rarely you can have gonadal dysgenesis. XY-DSD can have so many causes. The problems could actually be, and classically you will have the testes, but there are no Mullerian structure. It's maybe because of dysgenesis, which is NR5A1WT1, which we discussed, or impaired testosterone effect, either an effect in production of both adrenal and testicular situation in which you will have salt wasting. So this will be early defect, star, side chain cleavage, 3-beta HSD, or you have a distal defect in which only testosterone production is affected, or you can have 5-alpha reductase or AIS in which the testosterone is there, but it is not acting. Key feature of 17-hydroxylase is that you will have accumulation of mineralocorticoids, so it will cause hypertension, hypokalemia, and alkalosis. So hypertension with XY-DSD is 17-hydroxylase deficiency. Key feature of 5-alpha reductase is virilization during puberty. So they will have a normal female appearance, and then suddenly at puberty, they will tend to virilize in that scenario. And then finally, we have a sex chromosome DSD, which is a confusing picture of testicular and ovotesticular DSD in that perspective, where you can have both Mullerian structure and gonads which are present in that regards. So anybody who has an atypical genitalia is of course DSD, but if you have bilateral cryptorchidism, this could be the only sign of a very severe CAH, which could be life-threatening. So in this scenario, you need to evaluate carefully. Pinoscrotal hypospadia requires evaluation. A phenotypic male with bilateral cryptorchidism, pinoscrotal hypospadia or hypospadia with an undescended testis also requires evaluation. Phenotypic females with inguinal or labial gonads, now this is important for AIS, require evaluation, and of course if there is labial fusion. Very importantly, if a girl has primary amenorrhea, now I said all those conditions do not cause DSD. But if you have no estrogen production, if you have no estrogen action, or if there is a gonadal development problem, they will present with primary amenorrhea. So DSD may also present to you with primary amenorrhea in that regards. So look very carefully for the penile size, do a complete stretched penile length, and that will be important. Also look for the gonads. If you can feel a round gonad, which is well formed, it is usually testis. Rarely you can have a fallopian tube, which will have an erratic or an irregular margin, which is there. And uterus, you can do using a rectal examination or ultrasound. So always look for gonad and uterus. 99% of your diagnosis will be made based upon these two in that regard. So as I said, if you have no gonads, but uterus is present, this is XX-DSD. If you have gonads, but no uterus, it means gonads are there, they are producing AMH. So this is a XY-DSD. If you, however, have both of them, this is a confusing scenario, either AMH problem or a over-testicular DSD. If both are not there, it basically means that the testes were sometimes there, because to regress the Mullerian structure, AMH was produced at some point of time, but now they have gone. So either they are intra-abdominal or there is a anorchia which is there. So this will really help you to identify the cause. Now, next step is which investigation to do and when to do. So 17-OHP should be done in anybody who has a non-palpable gonad only after 72 hours. Very important, because before that you will have a falsely high level of 17-OHP. DHEAS, if you are thinking of a biosynthetic defect, this will give you a diagnosis. Androstenedione for 17-beta-HSD defect. Testosterone, which will give you a picture of 5-alpha reductase versus other forms, and DHT. Now, very importantly, you have a mini puberty. So during mini puberty, your LH goes up. In those scenarios, you do not need to do a HCG stimulation test. But if you have a child who is not into mini puberty, you would need to do a HCG stimulation test in that regards. AMH is a good marker of Sertoli cell function. So this is something which you can assess also. So HCG test should be done if your LH is prepubertal. You give HCG 5000 international unit per meter square and measure testo and DHT along with androstenedione at baseline and 72 hours. Remember, do not unnecessarily do a HCG test if your LH is already high. Somebody whose LH is 3, 4, you don't need to do any evaluation because the child is already into a mini puberty which is already there. So in XX-DSD, if you have very high 17-OHP, this is 21-hydroxylase deficiency. If you have high 17-OHP but less than 20 to 30, and you have very high DHEAS, this could be 3-beta-HSD. If you have a very high DOC with hypertension, hypokalemia, alkalosis, this will be 11-hydroxylase deficiency. And finally, POR is a very, very rare but confusing scenario. This will be there. For XY-DSD, all I am saying is that 4 will give you a diagnosis. Everything is low. It is a proximal defect. Star, side chain cleavage, all those defects. If DHEAS is high, everything else is low, you have 3-beta-HSD as the most likely diagnosis. If androstenedione is low, further is not being produced, it's 17-beta-HSD. If everything is high but DHT is low, this is 5-alpha reductase deficiency. If everything is high, it is AIS. So again, DHEAS and I would say testo DHT will give you most in this scenario in that regards. So how do you approach? And this will be the most important slide, and then we can go ahead with the cases. So if you have no palpable gonad, the next step is Mullerian structure. If Mullerian structure is yes, so it should be yes rather than no. If you have palpable gonad but no Mullerian structure, and you have got Mullerian structure, in that scenario, you look at 17-OHP. This is the most likely diagnosis. This is CAH. So uterus without gonads, CAH, high 17-OHP. 17-OHP normal, look at other rarer possibility. If you have palpable gonads with Mullerian structure, this is very rare scenario, and AMH is low. This is anorchia or dysgenesis. If it's high, it is AMH resistance. If, however, you have got no Mullerian structure, whether gonad is there or not doesn't matter. It means the gonads were there at some point of time at least. Look at testosterone. If testosterone is low and you have salt wasting, you think of a CAH variant. If you have hypertension, that is 17-hydroxylase deficiency. If everything is normal, think of things which are not affecting the adrenals, like the LHCG receptor defect or 17-beta-HSD. While if testosterone is high and DHT is low, this is 5-alpha reductase deficiency, and DHT is high, it is androgen insensitivity. So just by looking at gonads and Mullerian structure, you can classify, and then testosterone levels will give you. We will now move forward to the various cases which will really highlight the whole scenario. Dr. Vibha, please carry forward.
Thank you, sir. We have this 14-day-old preterm girl we got a reference for this girl, and with a concern regarding the clitoromegaly. There was no labial fusion, and there was no palpable gonads. So, Dr. Shalmi, how should we approach these cases in these preterm girls when we were concerned about the clitoromegaly?
Yes, thank you so much, Dr. Vibha. So I think the first question to ask here is, what is the length of the clitoris? Right? The main concern is that the clitoris is enlarged in size. So we need to know what is the length of the clitoris. So what is the length of the clitoris here?
Ma'am, it was less than 0.9 centimeter.
Yes, so I think that is the clincher, right? So any size of the clitoris which is less than 1 centimeter is not clitoromegaly. And often in the preterm girls, because their labia are not fully developed, they are sometimes gaping. We do see a clitoris which is more prominent rather than enlarged, right? As you mentioned, there is no labial fusion. Looking at the picture, there was no rugosity, no signs of virilization. Right. So this was just a prominent clitoris, which is often seen in the preterm girls without any signs of virilization. Do we have any palpable gonads or anything?
No, ma'am, there was no palpable gonads.
Right. So this is like very clear cut, right? So it is just a clitoris which is prominent, usually seen in the preterm girls, but this is not the case of DSD, and therefore unnecessary investigation should not be done. So again, very, very important would be the clinical examination. Just measuring the size of the clitoris tells us that the clitoris is not enlarged and it is very, very normal. So this is not a case of DSD, it is a normal clitoris.
So ma'am, what key messages would you like to give in this case?
So as we said, that prominent clitoris is not DSD, and therefore these patients do not need any workup. No, because workup can be sometimes confusing. This child was born preterm also. So again, there could be altered hormonal profile. So in this child, no workup is needed.
Thank you, ma'am. As ma'am has rightly said that the length of the clitoris is very important. So prominent clitoromegaly in preterm is common, and no need of workup is required in these type of cases. Yes. So moving towards the next case, we have this 3-month-old girl, and she was referred to us as there was no vaginal opening. There was no clitoromegaly, and the gonads were also not palpable. So this was the picture of the baby. So Dr. Varuna, is this really a DSD and is not? And is there a requirement of any further workup in this case?
Thank you, Dr. Vibha. So as we can see in this picture, and you have said that there is no clitoromegaly, there are no rugosities, there is no apparent sign of virilization present, and there are no gonads palpable. This child only has some labial adhesions. So no active intervention is required for this, and we just leave the child alone, and the child will probably outgrow these labial adhesions in some time. So these are just labial adhesions, and no active intervention is required for this.
So thank you, ma'am. So the key messages are the clitoromegaly is really essential for the DSD, and no workup is required for the labial adhesion. So moving towards the next case, we have this 2-month-old boy, and he was really he was sent to us for the concern of DSD. He was having penile hypospadiasis, and when we done the examination, his stretched penile length was 2.8 centimeter, and both the gonads were palpable. So, Dr. Sajali, how should we approach this case? Dr. Sajali?
So Sajali is not there, I think. Sajali, you are there? Let's check if she is in the... So while we wait for Dr. Sajali, I think this is an important case to identify that this child has a small phallic size, but there is no penoscrotal hypospadia. There is only penile hypospadia. So this is not DSD. We need to evaluate him from a perspective of micropenis, but not from a perspective of a DSD in this scenario. So clearly, no need for workup again.
Thank you, sir. So now we have a next case. We have an 8-year-old boy, and his parents brought him with the concern of small phallic size, as we can see in the picture. His height was 130 centimeter and weight was 44 kg. His testes were 2 ml bilateral. So, Dr. Purnima.
Thank you, Dr.
Thank you, Dr.
Vipa.
This case?
Yeah. So to move ahead with the case, first and foremost, we would like to know what is the development of this child, because obese and small phallic size, we need to look at hypothalamic pituitary gonadal axis as well as syndromic association. And second point would be to look at the weight and height centiles as well as the BMI. So clearly it shows that the weight is more than 97 centile and height is between 50 to 75th centile, and as well as BMI was coming up to the calculation of 26, which was beyond the risk of obesity.
Right.
And we also need to look at any external markers of syndromic obesity in terms of polydactyly, so which is not there. And the next step would be to look at this stretched penile length. So that is very crucial for us to determine for the further evaluation. So the most important is to do the correct method of examination for the stretched penile length. So we need to take a scale as well as measure from the dorsal aspect of the penis, which should be, the scale should be pressed against the pubic ramus so that the suprapubic fat is being compressed as well as stretched. And most important is it should be a non-erect penis and not to include the foreskin. So with that, if we could get the stretched penile length within the age norms and the population, then this child's SPL is 6 centimeters, which clearly indicates it appears like a buried penis and doesn't require any further workup.
Okay. Ma'am, what key message would you like to from this case?
So the key message over here is obese, normal development, and if there is the stretched penile length, which is a crucial step, which is within the normal age range, then which indicates it's more of a buried penis.
Thank you
more
so
in
much.
favor of a buried penis in obesity, and more of reassurance for the parents.
Thank you so much, ma'am, for your this expert advice. So this obese children with small phallic size is very common in OPD. So it should be kept in mind this is not really a small phallus. This is really a buried penis, and stretched penile size should be taken in every examination. Now coming to the next case, we have this 3-year-old child, and we got a this reference from the NICU. The NICU team was really concerned about this DSD. When we done the examination, the Prader stage was 4 and there was no palpable gonads. So Dr. Shalini, how should we approach this case?
Yes. So as sir mentioned earlier in the flow chart, right, that whenever we have a patient who has atypical genitalia, right, the first thing we ask is whether the gonads are present or not. So this child looks phenotypically like a male because there is a phallic length, there is something like a fused labioscrotal folds. But as you said, the gonads are absent. So then the next question to ask is whether the Mullerian structures are present or not. So are they present here or not?
Ma'am, the Mullerian structures were present.
Okay. So here we have a case where the gonads are not there, but the uterus is present. So
Yes.
most likely we are looking at a case of 46XX DSD, right? So probably this is a girl child who has been virilized. And the most common cause we know is CAH, right? So as you said, the next step is to get the electrolytes done, the 17 OHP level done. And as you rightly mentioned, there is a severe hyponatremia and hyperkalemia, and the 17 OHP levels are quite high. I believe these have been done after 72 hours of life, right? So, I mean, the child is already 3 days old, right? So there is no risk of it being a false positive result. So here we have a patient who has got non-palpable gonads, a uterus visit present, and quite a bit of virilization with hyponatremia, hyperkalemia, and a high 17 OHP. So this is a clear-cut case of CAH, the most common being 21 hydroxylase deficiency, right?
And what should be the gender of hearing in these type of child?
So as soon as you start the medication, that is your hydrocortisone and fluorocortisone in these patients, it is going to suppress the production of testosterone, right? And with some surgical correction, we are able to give a female phenotype to these patients. They are reared as females. So most of the patients of 21 hydroxylase deficiency are to be raised as females. There can be some issues with fertility later on, but it all depends on how well the CAH has also been managed. So we will do a female gender rearing for all these patients.
Thank you so much, ma'am. So,
yes,
ma'am, what key message would you like to give?
Yes, so a male-looking child, if the child has got bilateral cryptocortism, so if the gonads are absent, that definitely suggests DSD and the child has to be vigorously investigated. But remember the 17 OHP levels, because we know the most common cause is going to be CAH. It should be done after 72 hours of life to avoid a false positive result. But it is very important not to miss this, right? Because sometimes they are reared as males and then they come to us at the age of 1.5 to 2 months with severe adrenal crisis. So it is very, very important that we do not miss these patients.
Thank you so much, ma'am. Ma'am has nicely said that the gender of hearing is very important. The parental counseling is very important in these cases, and they should be reared as female only, because when we start the steroids, the testosterone will be suppressed and everything will be normal. Thank you so much, ma'am. Now moving towards the next case. Again, we have a 3-day-old child, and he was referred to us with a concern of DSD. And as we can see, there is a this splenomegaly, and we can see some scrotum-like structure. On examination, there was Prader stage 4, and again there was no palpable gonads. So, Dr. Varuna, this case is looking similar as to the previous case. Then how should we proceed this case?
So if this child had palpable gonads, that would have been testes, and we would consider that this child is having XY DSD. But in this case, there are no palpable gonads. So now we are dealing with the XX DSD, or there are some gonads which we are not able to localize. So the best thing at this stage would be to look for the Mullerian structures. So
and the Mullerian structures is present. Uterus is present in the ultrasound.
Okay, so if we see that the Mullerian structures are present, that means that we are dealing with the XX DSD, which has been virilized. So we try to see what is the cause of the virilization. So to see that, like in the previous slide, we should rule out 21 hydroxylase deficiency, because that's a life-threatening thing, by doing 17 OHP levels and deoxycorticosterone levels to rule out 11 beta hydroxylase deficiency. So the two forms of congenital adrenal hyperplasia.
17 OHP was mildly elevated. It was 25 nanogram per ml.
So this is not a significant elevation enough to diagnose 21 hydroxylase deficiency. So I would say let's go back to the history of this patient and see if the mother has any features of virilization during the pregnancy or not.
Yeah, surely they gave the history of maternal virilization during the pregnancy. So
we are dealing, if there is maternal virilization, then we are probably dealing with aromatase deficiency in this patient. So
what is the gender of rearing in this case?
So the child has got Mullerian structures. There are no testes. So definitely this child should be reared as a female child. There is no point in rearing her as a male. And because it is aromatase deficiency was there in utero, once the child has come out of the uterus, there will be no further increase in the virilization, and appropriate surgical correction may be done after a few months.
And what key message would you like to give?
So the key message is that number one, the most important thing is history. So if there is a history of maternal virilization, we should strongly consider a possibility of aromatase deficiency. And second, if we are dealing with a child where there is no gonad and uterus is present, we are dealing with the XXDS.
Thank you so much, ma'am. Ma'am has nicely said that we should not rush into the diagnosis of CH in every case with the non-palpable gonads and virilization. There is a possibility of aromatism POR if there is a history of maternal virilization. So now coming to the next case, we have a 14-day-old child and he was referred to us with a concern of DSD. As we can see clearly in the picture, the child has clitoromegaly and the bilateral gonads was palpable. On the ultrasound, there was no uterus and the karyotype shows XY, 46XY. So Dr. Sajali.
I think Sajali was unable to join. So this is a classical scenario of somebody who has got bilateral gonads and no uterus. So this is a XY DSD. Now XY DSD, your first question is whether this child is going to go into crisis. So you have to look at whether it is a combined defect, combined adrenotesticular defect, or a defect which is post or a resistance effect. So we have to look at predominantly DHEAS, testo DHT, which will give you a clue. Now in this scenario, you've got palpable gonads, the uterus is absent. So this is a XY DSD. What I like to look at clearly is that day 14, whether there is salt wasting or not, because I don't want to miss it. In this scenario, you have hyponatremia, hyperkalemia, and mildly elevated 17 OHP. So this is again a salt wasting, which suggests that there is a early defect which is happening, but there is not that level of elevation of 17 OHP to diagnose 21 hydroxylase. And of course, this is XY DSD. So this cannot be 21 hydroxylase deficiency. This is a classical picture of 3-beta HSD as a likely diagnosis. So if you have a palpable gonad with DSD, with hyponatremia, hyperkalemia, think of a possibility of 3-beta HSD in this scenario. That will be the key message. The gender of rearing clearly here will be, depending upon the various scenarios, there will be androgen exposure which is there, and you can manage from that perspective. If you give androgens, you will be able to manage them as males and rear them as males in this perspective. So of course, if you have gonads with no uterus, think of XY DSD. And if you have salt wasting, think of 3-beta HSD. Now, Vibha, why do 3-beta HSD cause DSD both in a XX and a XY individual?
So because of the peripheral conversion of because of the peripheral conversion in the 3-beta HSD, the androgen formed is not is enough to cause virilization in the male. So it causes this DSD in the male, but it is enough to cause virilization in the female. That's why it is able to cause virilization in both the sexes. So
3-beta HSD2 is the one which is there in the adrenals. 3-beta HSD1 is in the placenta, in the liver, in the peripheral tissues. So you produce so much DHEAS, it gets converted peripherally into some amount of testosterone, which is not good enough to virilize the male, but it is good enough to virilize the female. So POR and 3-beta HSD are two conditions which cause both DSD in XX as well as XY.
Next slide. Go.
So now coming to the next case, we have a 14-day-old child. He was referred to us with a concern of DSD. And as we can see clearly in the picture, there is a one side we can see there is a scrotum present and there is a penis present. So he was referred to us with the asymmetrical gonad and testis was present on the right side. And on the USG, uterus was present. So Dr. Purnima, how should we proceed and what should be the plan of management in this case?
So thank you, Dr. Vibha. So what we could see the picture is, one is there is a unilateral swelling, which is looking probably like a gonad. And we need to look at the presence of gonad on the other side or somewhere in the inguinal or abdomen, as well as it has already been mentioned that uterus is also present over there, which indicates both testis and uterus being present. So, which is an indirect indication that anti-Mullerian hormone is deficient, which is again telling us probably certainly cell function is being affected, and indirectly, which tells us probably gonadal dysgenesis might be there. So, looking into our classification of DSD as 46XXY sex chromosome. So, this in neonate clearly falls into sex chromosome DSD, which is rare. So, on approaching this neonate, we looked at the palpable gonads, and which has been present, and Mullerian structures are also present, which the next step would be to look for the anti-Mullerian hormone. If these hormones are low, then we consider it could be because of anorexia or gonadal dysgenesis. So the diagnosis would be over-testicular DSD. So the key message over here is presence of uterus as well as the testis will tell us clearly it's an over-testicular DSD with an asymmetrical genitalia, and it's a social emergency for assignment of the gender in this newborn.
Thank you so much, ma'am. So now moving towards the next case, we have a 15-year-old girl who came to us with a complaint of delayed puberty. When we done the examination, we found there was a gonads which were palpable in the inguinal region. And when we done the USG, there was no uterus. So Dr. Shalini, could you explain us with what type of case we are dealing with?
Yes. So, DSDs can present later on in the life also, especially when a child enters puberty. So it is not always that we see DSDs at the time of birth, right? So again, we go back to our flow chart and we ask the basic questions. So here we said that we were able to find a gonad, which was there in the inguinal region, but the uterus, so no Mullerian structures were present. Now, this child has not developed any signs of puberty, right? So we need to know whether these gonads are functioning or not, or like whether they are making testosterone or whether the testosterone is, it is acting or not. So whether there is any receptor problem or there is any problem in the steroid synthesis. So as you rightly mentioned here, the testosterone synthesis is not there. Testosterone levels are very, very low. And if you look at the FSH levels, they are quite high. So probably there is a primary gonadal failure. The gonads are not working. If we just go back to basics, gonad present, uterus absent, so it is going to be a 46XY DSD, right? So that is the basic thing that we have derived already, that we are dealing with a case of 46XY DSD. So though this patient has been reared as a girl, the patient is genetically an XY, right? But because there is something wrong in the steroidal pathway, the testosterone production was not there, and therefore the child has always had a phenotypic female. Then the next question is whether, there is a problem in only the testosterone synthesis or also in the adrenal axis, right? So that is why we ask for the sodium status. So what is the blood pressure like? Is there any hyponatremia, what is the status of the potassium levels?
Blood pressure
Yes.
was high. And
so here the blood pressure is high. So I think if we didn't look at the blood pressure, because sometimes we often miss looking at the blood pressure, the child doesn't present with any symptoms of headache or, dizziness. We just don't check the blood pressure sometimes. We are going to very much miss this patient, right? So here this child is a 46XY DSD. The child has hypertension and mild hypokalemia also. So what is happening is there is some blockage in the production of testosterone, but the precursors are causing hypertension. So this is a case of 17 hydroxylase. Yes, so this is a case of 17 hydroxylase deficiency.
Yeah, very rightly said, ma'am. What key message would you like to give in this case?
Here, so any patient who comes to us with primary amenorrhea, right? The child has not developed any signs of secondary sexual characters, and the gonads are present, but the uterus is absent. So we know we have XY DSD. At the same time, if we come across that child having hypertension, we are dealing with a case of 17 hydroxylase deficiency. So we should not miss these patients. We should always check blood pressure in all our patients who present to us with amenorrhea, delayed puberty, or DSDs.
Thank you so much, ma'am, for giving us this clue. So measuring BP is really important, in which most of the people really miss. So in the clinical patients of primary amenorrhea, please measure BP in every patient.
Yes.
So now we have a patient of 12-year-old boy who came to us with a complaint of hematuria, and there was no palpable gonad. So, Dr. Varuna, what's wrong with this patient? Kindly guide us in this case.
So if this child is coming to us at 12 years with hematuria and there is no palpable gonad and he has not been worked up till now, he may be a case of DSDs. We really need to look for those gonads and see what is this child is suffering from. So we have no, we did, like you said, that there are no palpable gonads. So the next thing I want to see for are Mullerian structures.
Uterus was present, ma'am.
So if uterus is present, if there are no gonads, then we are dealing with a virilized XX DSD, and probably it's the uterus now that is the child has attained menarche. The hematuria is actually menstrual blood that is coming out. So now we need to look for the cause of this virilization.
And when we measured the BP, as it was discussed in the previous case also, it was 160 by 110, which was quite high.
So we have hyperpigment, we have hypertension as well as virilization. So then we may be dealing with some form of CA. So we should do deoxycorticosterone levels. So this child was younger, had presented with hypotension and with salt wasting, would be more interested in doing 17-OHP. And 17-OHP can also present as a simple virilizing variant as well. But with hypertension is more likely to occur if in patients with 11 beta hydroxysteroid dehydrogenase deficiency. And we really need to see the deoxycorticosterone levels.
Yes, ma'am. DOC was very high. And as you mentioned, it was 11-dehydroxylase deficiency. So, ma'am, what key message would you like to give? And what gender of hearing would you really counsel about for the parents?
Well, it is a very difficult situation. 12-year-old boy, this child has been reared as a boy till 12 years of life. Now to change the gender is going to be really difficult for the parents and for the child also. So biologically, this child will never be able to function as a male because he will never have gonads, never have testicular tissue, and he has a uterus. So biologically, definitely this child needs to be reared as a female and should have been identified long ago. But otherwise, we should, now that he is 12 years old, we have to keep all the social and psychological factors also in mind if we are going in for any kind of gender reassignment.
Thank you so much, ma'am. Now moving towards the next case. Now we have a 15-year-old girl who came to us with a complaint of primary amenorrhea, and she has a height of 154 centimeter with a weight of 48 kg. And she has a breast stage of 4 and pubic hair too, sparse pubic hair, and she has a inguinal gonads. So, Dr. Sajali.
So now this is an interesting case which we discussed also as part of the pubertal course. So this is a child who is having a primary amenorrhea with normal breast development, but no very sparse pubic hair development, and also inguinal gonad. So this clearly means a situation that there is a production of estrogen, but that estrogen is probably there, but it is not producing vaginal bleeding because of some issues, whether the uterus is there or not. That becomes a primary thing. The other important thing is that the androgens, because whenever you produce estrogen, you should also produce androgens, and adrenals will also produce androgen. You have good breast development, but you have got no pubic hair or less pubic hair development. So what it is saying is estrogen is working, androgen is not working. So this basically means this is a classical androgen insensitivity syndrome. So a normal looking girl with a breast stage, which is stage 4, no pubic hair development, the first thing to look at is the Mullerian structure. In this scenario, which will be absent, this will classically be a XY DSD, a complete AIS is the picture that we are looking at. So any girl who has a primary amenorrhea with no pubarchy, think of androgen insensitivity syndrome, they will of course have to be reared as female because they have no androgen exposure at all to the brain. They will always behave like females. They may feminize during puberty. So if you want to do a gonadectomy to remove the testis, we should do it a bit later after puberty, once normal development has happened.
Moving towards the next case, we have a 10-year-old girl who came to us with a recent clitoral enlargement. The phallic length was 2.2 centimeter, and she has a gonads of bilateral palpable. So, Dr. Purnima, could you please, Dr. Purnima?
Yeah. Thank you, Dr. Vibha.
Okay. Could you please?
This is a 10-year-old girl, peripubertal age, with a clitoral enlargement with a phallic length of 2.2 centimeters. Definitely indicates it's enlarged. And in the presence of bilateral gonads, I would like to look at the presence of Mullerian structures in this child, in this girl.
Are absent, ma'am.
And uterus is being absent. And the next step would be to go for the chromosome analysis. A karyotype is indicative of 46XY. And the next step would be to look for the hormonal evaluation in terms of testosterone. So testo is being high, 170 nanogram per deciliter. And in the presence of high testosterone, the next step would be to look for dihydrotestosterone, so which is low. So which is clearly indicative of 5-alpha reductase deficiency. So the key message is peripubertal age, virilization, new onset virilization is always suggestive of 5-alpha reductase deficiency. And the next step of management is to consider male gender of rearing in this girl because of the presence of bilateral gonads.
Thank you so much, ma'am.
So I think I'd like to thank all the panelists for being part of it, Dr. Varuna, Dr. Sajali, Dr. Shalmi, and Dr. Purnima and Dr. Vibha for this. We have developed a DSD interpreter which uses very simple tools of whether the gonads, the same algorithm that I talked about. Once we enter these data, you will get the results immediately to interpret that. And it will give you a specific diagnosis. So this is one tool which you can use. So all this we discussed over the last 50 minutes or so is available on the mobile application to look at and to identify. So at the end, I'd like to again thank all of you, Dr. Shalmi, Dr. Varuna, Dr. Purnima, Dr. Sajali, who couldn't make it because of certain problems, and Dr. Vibha. We'll see if there are any particular questions which are there in that regard. So there is a question which is there from Dr. Syed Farooq Ali. Is there any Indian study data for age-specific penile length or SDS? There is. Dr. Vaman and Dr. Vijay Jaiswal did a study on the penile length. So it's available, I think, from the Indian Journal of Endocrinology and Metabolism, which provides you a data on that. Not with regards to the SDS, but with regards to the age-specific length. Dr. Denise from Mexico is asking, is there a level degree of maternal virilization to predict a non-DSD abnormal external genitalia in a newborn in order to work up with obs and gynae? Generally speaking, Dr. Denise, that if the mother is virilized, all the androgens which is there will be actually inactivated by the placenta, because placenta is very effective in that perspective. So unless the placenta has an aromatase deficiency, we do not expect that to happen. So this aromatase and 17-beta-HSD will inactivate the maternal one. So we don't expect a virilization in a child just because the mother is having that. If there is too much production, like a luteoma, like there's a clear virilization which happens in puberty, that may happen. Otherwise, we should not really concern that this will cause an overall effect in that perspective. So I think we had a very exhaustive discussion now for over 4 hours, and a lot of people have joined across the globe who are still there. And we like to thank the panelists, Dr. Shalmi, Dr. Varuna, Dr. Purnima, and Sajali, who couldn't join in, and Dr. Vibha for being part of this. I thank all of you, and we'll be closing the session now. And we will join tomorrow around 2 p.m. Indian time with regards to the sessions on emergency pediatric endocrinology on calcium, electrolyte, DKA, and hypoglycemia. Once again, thanks all of you.
Thank you so much, sir, for the chance.
Thank you, Dr. Shalmi, Dr. Varuna.
Thank you so much for the wonderful opportunity, sir.
Thank you. Thank you, Dr. Varuna, as well.